evening, everyone. We appreciate everyone who's joined us tonight in our community. Obviously, I'm Dr. Castone, Superintendent of Schools, and welcome to our Public Health Town Hall. Before we get started, I wanted to just give our panelists an opportunity to introduce themselves. We have some folks from the township, but also some new, perhaps some new faces. So, Dr. Josephs, would you like to start?
Sure, thank you very much. So my name is Joshua Josephs. I'm a physician practicing in Hackensack as a hospitalist there. I also have degrees in infectious disease epidemiology from Johns Hopkins and in general epidemiology, my doctoral degree in that from Emory University, and have done a fair amount of research on healthcare inequalities and disparities in my career. And then for the past 10 months or so, I've been taking care of COVID patients who've been hospitalized up in Hackensack.
Thank you, Dr. Josephs. Dr. Campbell?
Good evening. My name is Donnelly Campbell, and I am a physician. I work in a Safety Net Hospital in New Jersey, in Newark, New Jersey, and I also am on the Professional Advisory Committee for the Health Commissioner for the state of New Jersey. I've been working through the pandemic, and as well as a parent, as many people who are on this forum, and I'm happy to give information and help out.
Thank you, Dr. Campbell. Dr. Schurz.
Hello, my name is Jared Schurz. I'm a clinical psychologist, and I work with school districts here in New Jersey and throughout the country.
Dr. Chase. You're on mute, Dr. Chase. Yeah, you're on mute.
I'm on mute, and I apologize for that. I am Dr. Jill Chassé. I'm a clinical epidemiologist, doctor of public health and integrative medicine. Spent the last 10, 15 years in federal public health education and field epidemiology. I currently teach at William Patterson University in public health as well. And recently I left the CDC to take a position of Director of Public Health and Operations for a telemedicine company, also doing infectious disease and health literacy and education.
Thank you, Dr. Chassé. Strick-Scales.
Hi, good evening, everyone, and thank you to our panelists, first of all. And we have a sizable number of our community members here, and we're delighted that you're joining us for what I think will be a very informative evening. And I am Terry Strick-Scales, and I am the board president.
Thank you, Ms. Strick-Scales. Nurse Iovino? You're on mute, nurse.
I'm Susan Iovino, the Senior Public Health Nurse for the Township of West Orange. I've been with the town in the health department as a nurse for almost 30 years, since 1990, working in the communicable. One of my areas of specialty is the communicable disease investigations.
Thank you, Nurse Iovino. Mr. Fonzino.
Good evening, everyone. My name is Michael Fonzino. I'm the Chief Registered Environmental Health Specialist with the West Orange Health Department.
Thank you, Michael. Dr. Kelly? I think you're on mute, Dr. Kelly.
Hello, I'm Dr. Kelly. I'm the school physician for West Orange for the past 8 years, as well as a number of other school districts in New Jersey.
Dr. Kelly. And Ms. Nova?
Good evening, Dr. Castone and rest of the panel and public. I am the health officer for the Township of West Orange. I've worked for the township for over 40 years. I've been the health officer for the last 10 and the assistant health officer for 25 years before that. And we're here tonight to assist in any way we can to provide information to the public regarding COVID, which has been very challenging and we're looking forward to participating.
Thank you, Mr. DeNova. Mr. Algrino.
Good evening. Thanks, Doc. Nick Algrino, OEM coordinator for the town of West Orange. I've been with the Office of Emergency Management since 2010, with the town for the last 25. Started as deputy coordinator, was recently moved up to, or appointed to the OEM coordinator in December of 2019.
Thank you, Nick. So thank you again to all our panelists. So just to kind of narrate to some extent kind of what has brought us here today, and I know I've communicated it, to the community over the course of the last couple of months, but I think it merits repeating. So as you know, in early November, we were scheduled to do a full STEAM implementation of our hybrid model, K-12, pre-K through 12, although our pre-K students were already in at that time, and our autistic students. And early November, around November 2nd, district physician and then the local OEM reached out to me and really just kind of, created a moment where we could consider what we were about to do as it related to the public health situation. And what were we observing in early November that was different from what we had seen in September, October? Well, we were seeing an uptick in cases. Okay, we hadn't seen that really since the previous spring. And there was really no telling where that was headed. We also knew that we were heading into cold and flu season. We were heading into the holidays with travel and social gatherings. And so really the advice was postpone, evaluate. Let's get a sense of where this uptick is going. Is it going to double? Is it going to triple? It's going to quadruple. What's it going to do? And so we were recommended that we postpone, and we did. I understand that there were many folks, including some of our students, who were disappointed by that. And so our community members rightfully were looking for clarity on if it wasn't safe then, when would it be safe? What would we use as a metric to determine and to measure when we were coming back? But before I talk about that, I just want to talk about the idea of if it wasn't safe then. And I want to clarify that there was nothing about that particular moment in time that was intrinsically unsafe. It was the uncertainty of where it was going to go after that. Was it going to get more unsafe and exponentially more unsafe? That was the reason for postponing, really. And that really was how Dr. Kelly articulated it to me. But nevertheless, we understood that our parents were interested in how are we going to know when we feel that it's appropriate to come back. And so in collaboration, really primarily with Dr. Kelly, and I'll be honest with you, we wrestled with what's a reliable and valid metric. I think, and we'll talk about this in a moment, we really need to be looking at multiple metrics. We know anytime we're doing research or even evaluating student progress, we look at multiple measures and not a single metric. But we settled on local positivity rate. And why'd we do that? Well, because it was accessible, it was localized, so it was not kind of adulterated, if you will, by more aggregated data. And so we went with that, and we connected it to our COVID-19 risk matrix. And we said, you know what, we want to feel comfortable that we're in the moderate range of risk before we make a go of this. Now, if you recall, around early December, as a matter of fact, Nick Algrino reached out to me and he gave me a heads up that the Department of Health was shifting gears in terms of the way they were going to calculate local positivity rate. And they were going to pivot to align their formula with the same formula that was being used on the state and the county level. And we'll delve into that a little bit more in the panel. And when we looked at that difference, and Nick, I'll ask you to correct me if I'm wrong, but the previous formula was an aggregate, a longitudinal aggregate of positive tests over a longitudinal aggregate of total tests.
Correct. It was the cumulative number of all tests received at that point.
Right. And the new formula boiled that down to just the last 7 days.
Yes, we're taking the average of the last 7 days at this point.
Right. So when you change that formula, what we saw is that the positivity rate actually went down. Now, knowing that I had framed this discussion around opening around the local positivity rate and looking at that high end of 10%, I knew that in speaking to public health experts, hypothesizing that we were going to see we could very well see a decrease after somewhat of an uptick around the holidays. And obviously we've been through that. The data that we're looking at right now is reflective of that holiday data. Is it, Dr. Chasse, would you and Dr. Joseph, is that an accurate statement? Okay. So
Or I was on mute. Yes, I agree. And that's definitely what you need to look at. It's not the data all along, it's within the last 14 days.
Okay.
And absolutely, since we've been more than 14 days since the last holidays, I agree.
Okay, so thank you. So and knowing that the operation of preparing to open is not calling folks up and be like, okay, like we're coming in Tuesday. Like it is a multi-week process of understanding of articulating those expectations to our staff in terms of the timeline, and then going through the interactive process of understanding who's able to be here on site teaching and who isn't, and then having the process by which we attempt to find replacement teachers to fill in their absence. So here we come towards to the present time, and we start to see that we get a local positivity rate of 8%. We get a local positivity rate of 10.3%. And I'm just, because it's in the flow here, Mr. Allegrino, if you would just for the audience, talk about if you were to calculate the 7-day positivity rate today on the last 7 days, and if you would be clear and explicit on the cases and the math and the results.
So, right, if we reported today, if I gave these numbers to the mayor today to report on this daily report, which, by the way, is I am the one who provides these numbers to him. He doesn't do these calculations himself. Today's 7-day positive cases would be 173 positive. It would be 138 negative for a total of 311. So we would take that 173, divided it by 311. We multiply it by 100, and then we take that number and divide that number by 7 to give us the 7-day daily average positive cases.
And that would give us what percentage?
That was 7.94 or 8 to round up.
Okay, Doc, and just because I understand that there's some, and I'd ask either Dr. Josephs, Dr. Campbell, or Dr. Chasse to weigh in on this question, or Dr. Anna or Dr. Kelly, any of the physicians, is that an accurate formula for calculating positivity rate from your perspective?
Yes, I think it's one of several accurate ways that one could approach this question. What you have to remember is that because it takes a period of between 3 and 7 days for somebody to develop symptoms of coronavirus infection, that the numbers you're talking about really represent people who were infected probably between 7 and 10 days ago by the time they had symptoms severe enough that they went to their physician or of their own accord went to urgent care and felt like they had to be tested. The other thing to remember is that testing is still somewhat hard to come by, although we're a lot better off in the spring. So there are many people who are just assuming that they have coronavirus and staying home and not getting tested. And we don't really know whether they have it or not. So both your top number, your numerator, and your denominator may not be accurate, and we don't know which way they're inaccurate. But we do know there are people who aren't getting tested out there still. But I think this is one of the simplest and easiest easiest ways to do it. And I think it creates a relatively accurate measure of the percentage of positive tests.
Thank you, Dr. Joseph. And I forgot to mention this. I forgot to state this at the onset because I intended to just kind of do an uninterrupted monologue, but I'm riffing here and ad-libbing a little bit. But I just wanted to preface before the panelists spoke that one of the things that I said to our panelists, in our meeting room before we came in, is that I'm asking for their unvarnished, honest professional opinion, and I'm encouraging them to share that, whether or not it is necessarily in sync with our reopening plans, which are on tap for the coming Monday. So I just want to state that publicly. And just reiterate that to the panelists is that I want you to speak freely and honestly to the questions, and I appreciate it. So we come to this point in time now. This final piece is going to kind of lead into the first question, for the panelists, which is we get back to this idea of multiple measures and multiple metrics, and so we have our local positivity rate. We have an average county positivity rate. And unfortunately, I had tried to get the county health director to come tonight, but she was unable to attend. Nick, do you have, I know last I asked, you didn't have the most current county positivity rate, but what's the most recent county, or does and if anyone else on the call has data as to the county positivity rate, but what's your understanding of that?
I don't have it in front of me, and I apologize for that. I will look for it before we leave for today, and I'll see if I can try and get it.
Okay. I mean, I know it's hovered on or around 10%, meaning it's relatively in sync with our local rate. And then of course you have a third metric which we look at, which is that regional risk matrix, which is the aggregate of all municipalities within your region, in our case, including Newark. So as you get more aggregated, I would argue, and actually I shouldn't argue anything. I should pose that question to the experts. And maybe that's a good tee up for the first question, which is how do we contextualize these different metrics? How do we relate the local positivity rate with the county positivity rate and the regional positivity rate? What do these numbers really mean in of themselves and collectively? And I would offer that up to Dr. Chastain. Would you like to?
Yeah, I was going to say, if nobody else is saying anything, what we're looking at for this particular disease really is the community burden. So what is higher for the state isn't going to be as applicable to where we are. We need to look at our indicators. Our core indicators are it's the measure of community burden. And community, again, which is the smaller number from looking at the state versus looking at the county versus looking at, maybe the area. People may be concerned because yes, New Jersey is high. Yes, New York is high, and we are in the New York metropolitan area. But for SARS-CoV-2, for COVID specifically, we are looking at the indicator being the community burden. Our community rate is low. And so this is more important than looking at the number that's higher for the state. So that addresses the question.
Dr. Campbell, Dr. Josephs, anything you'd want to add to that?
Well, I would just say it's really hard to, because we're in a big county, Essex County, so it's really hard to lump that one county. You don't get a really full picture of the burden. I was trying to pull up that positivity rate on the state website, but I know for a fact that they not only can track the positivity rate by county, by city, but even by zip code. And so, for example, even in the city of Newark, you have certain areas that have a much higher positivity rate than other areas. of the city. So the same thing would be for our areas outside of Newark, West Orange, West Caldwell, all these different places. That burden looks very different. And because we're in Essex County, and because of the city and people's inability to social distance and have that space, you're going to see our county rates a little bit higher, and that may worry people, but we really have to be more specific.
I would say the one other number we really haven't referenced so far in our discussion is what's called R0 or R0 or RT. They're all terms for the same thing. What they reference is how many new cases of disease is a current case creating. And so if the number is equal to 1, that means everybody who's currently infected generates 1 new case. If it's 2, you would have 2 new cases for every current case. If it was a half, you would have half a case. I know it's hard to conceptualize a half a case of a disease. So think about it as if you had 10 people infected, they would make for 5 new infections. So anytime that number is less than 1, the epidemic overall will be shrinking in size. And anytime the number is greater than 1, the epidemic would be growing in size. The state of New Jersey does not publish estimates for this, to my knowledge, on the county or municipality level. There are some epidemiologists out there who have their own websites up who are. I've not gone through their data in detail to be completely confident in their calculations, but I trust they're not trying to fool us. And they say that in Essex County, the number is almost exactly 1, which suggests that for the past couple of weeks, our epidemic has been stable in size in the county. I don't have more localized numbers for individual zip codes or municipalities, but and that number holds true for New Jersey overall from the data I've seen from the state. It's right around 1 right now, maybe just a touch less, 0.98 or 0.97.
So Dr. Josephs, just to thank you, and just to continue that line of questioning, some would, as a layman, I might see a sort of a disconnect between that, right? Like, because based upon what you're telling me, that sounds positive. Yet we have a state that's across the board in the high risk. How do you reconcile those? Is it a disconnect? If it isn't, how do you reconcile it?
Yeah. So the way you reconcile it is by understanding what happened over the holidays. So between about November 15th and the 30th of December, that number was 1.3 or 1.4. So when the number is that much greater than 1, the epidemic really takes off and quickly. So you infect a very large number of people. So then if the number becomes 0.98, you're only very slightly less than 1. So it takes a very long time for the curve to come back down. And so what you have is a lot of people out there infected with COVID, and the amount that the pandemic is shrinking on any given day is very small. So it's going to take a very long time. And I can try to pull them up in a couple of minutes and show graphs of what happened in the spring. But even in the spring, when we went on lockdown, we never really got that number less than about 0.8. And it really took about 3 months to drive the number of cases in New Jersey to that very low number that we were then able to sustain during the summertime. And then, of course, we've had isolated spikes with the holidays, July 4th, Memorial Day, Labor Day, et cetera, until we came to just the core of the holiday season when things got bad.
Thank you, Dr. Joseph.
Doc, if I may,
yeah.
as of the 13th of January, the county positivity was 11.37.
County was 11.37?
As of the 13th.
Okay. 13th of January.
January, correct.
Let's just switch gears just a touch, just to kind of, and we can come back to some of that. Dr. Schurz, being the humble man that I know you to be, you were very coy in your introduction, but I think I'd love for you to share a little bit more detail about some of the work that you're doing in schools first. And we partnered with you, for our staff PD and supporting social emotional well-being of students and staff through your teacher coach platform, which I just note was offered to us gratis this year. Talk to us a little bit about that work, and then can you speak to the mental health side of this as you've seen it, both as a clinician but also as somebody that's really integrally involved in working with schools?
The main thrust of our work over the last year, as everybody could imagine, has been the mental health of school communities, including the faculty and the families. Trying to figure out how to support people who are sort of surviving, how to not inoculate against stress, but at least how to prevent stress from becoming toxic, how to improve resilience in both children and adults during this chronic duress. And it's been extraordinarily challenging because, like living in a war zone when the threat doesn't abate, that we continue to suffer in all kinds of ways. And one of the sort of interesting ways that people suffer is that perceived threats, things that we might not have seen or experienced as intense or severe, now become more intense because we're living in that hypervigilance, in that constant state of readiness. So everything we experience now becomes alarming. So we respond to our coworkers, our friends, our family members, our children, our community in this air of cautious guardedness and even agitation because we are expecting everything to harm us, which is a natural sort of state of readiness for people during this kind of prolonged experience. But no one has experience in this kind of tumult. There's lots of research going on about the intellectual and cognitive development of children, which we can talk about. There's the psychosocial, emotional aspects of this, which we can talk about. But in general terms, we know that anxiety has gone up significantly. Some estimates look at 3 times what it was prior, quadruple the number of depression cases have. And we also know that suicide is up at an alarming rate. Right? I see Dr. Chess, right? One study shows 1 out of every 4 young people contemplating suicide right now, which is a sort of an aggregate of all of the different threats, but primarily we can speculate the isolation and contact being cut off or needs not being met. So it's very alarming, and especially on minority populations, because depression and suicide was already going up. Suicide has gone up since 1999, I believe, about 35%. And that was measured before this pandemic. So
but this last year, it's jumped up significantly.
Frightening to think about. And it's not going to end because even when the threat abates, even when we might be out of harm in terms of the acute health concerns, there are still going to be long-term mental health concerns. So that's sort of a general umbrella of what I've been trying to help with both here in New Jersey and around the country.
And to piggyback on that, in the pediatric population, especially because a lot of the children don't understand. And to kind of jump in my introduction, I kind of left out the fact that I have a background, master's and a bachelor's in psychology. And a lot of my work with CDC was the psychological aspect of a lot of our patients, especially our patients in tertiary care. And we saw a lot of the children. And I think this is extremely applicable. We're talking about schools because these children are having a very small percentage of their time during their day socializing. And we're social creatures and we need this. And adults could find other outlets. Children, it's very difficult to find other outlets. Not only as Dr. Shez said, the risk went significantly up with suicide. But, again, children that already had mental health issues, adults that are home with children that may have like perinatal mood and anxiety disorders is off the charts. And, you think, okay, we're talking about school children here. Well, parents who have children in school, especially elementary and middle school, that may have another child are now, if dealing with perinatal mood and anxiety issues at an extremely high rate, which makes it more of less of a supportive structure. So they don't really have that support that they would have at home if it wasn't for the mental health issues. And that's something that they could get in school. And yes, I know we are kind of talking about the risks and the benefits. But again, to talk about this depression that, I know you had mentioned the anxiety as well, but there are other things. There are, children who have learning disabilities, special needs. They are suffering, especially because they can't understand a lot of this. And this hypervigilance is really putting a lot of people on edge, especially our children.
Thank you. Dr. Campbell?
Well, I just wanted to comment and maybe ask the doctors to also comment. One of the things that we see is also that there is a stigma surrounding anxiety and depression, and that affects people even getting that addressed. And, there's an access issue to mental health services. And in my own field, I know, we have documented drops in calls about domestic violence and interpersonal violence, and all of those things play into some of these mental health issues, and how, personally, I'm concerned in how that affects children and their ability to have an outlet. So I would love if you would comment about that as well.
Dr. Scherz, you want to take that?
It's absolutely unthinkable what we are having to manage right now. Nobody has lived through this lack of control, this helplessness, this lack of hope, this lack of fun and socializing, a lack of intellectual stimulation. And now when we superimpose that on families who are disadvantaged or coming from impoverished communities with a lack of resources, and we add in a stigma, as Dr. Campbell said, about seeking services, it leads to very unfair or even oppressive kinds of living experiences for families. So I would suggest to the people who are listening that there's a certain strength that comes with vulnerability, allowing yourself to acknowledge that you're being impacted and that you could use some outside support. And it's a great way to model for children and other young people that we all need help. As a psychologist, I wouldn't think of not getting support for myself, because the amount of caretaking we're doing for others is depleting us of our resources. And we need to be constantly infusing ourselves with enough good energy, both to support our psychological strength and our physical immunity, because they go hand in hand. We've got to eat well, right? We've got to eat the right kinds of foods. We've got to learn new strategies for coping with this very new kind of experience. So I really encourage folks, and thank you for the question, Dr. Campbell, to make it a priority to investigate and explore what kind of supports are out there.
Thank you, Dr. Scherz. So let's you're getting a window into the way my mind works. Let's switch gears again here. I think one of the questions, and as a superintendent, kind of advocating and trying to represent and advocate for the interests and the well-being of not only the students and the parents, but obviously for our employees. As a relatively new superintendent to the district, the staff's belief in me as a superintendent, my credibility as a superintendent that, that is supportive of them, that is mindful of their well-being. When we talk, so we have a state that's completely in the high range, and yet we have many school districts that are in, and are allowed to be in, right? So they're not being told by the Department of Health or the governor, you can't be in. And I understand for people that there's a disconnect there in their mind. How could this possibly be the case? How could we possibly be bringing people into schools at this time? And this, I think, is a throw up for anyone that wants to grab it. How would you respond to that? How are we able to open schools with a relative degree of safety when we have regions in the state that according to the Department of Health index are in the high range? Dr. Josephs, you want to take that?
Sure, I can start, and I think there's lots of other people who have thoughts, but there's really two pieces to it that you have to think about when considering the safety of the people in the school. So of course, first off, there's the children in the school, and then there's the adult staff who are in the school. So let's start with the children first. I'm not a pediatrician. I take care of adults by practice, but I have looked into this a little bit. Children, as a general rule, two things to consider. One is, and this is very unusual for an infectious disease, but it seems to be the case with coronavirus, do not seem to readily get COVID. We don't really know why that is, because virtually every other infection, it's the opposite. Kids get it super easily compared to adults. But that seems to, so that's the first piece. The second piece is that even for children who do acquire it, the risk of a bad outcome, meaning being hospitalized or having the inflammatory response that people might have heard about, or heaven forbid, passing away from it, is exceedingly, exceedingly rare. It's on the order of just pretty much non-existent. There are cases, but it's very uncommon. So that's the children and what happens if they get COVID. Then there's the staff and the risk to them if they have COVID. And that really, more than anything else, is a factor about two things. One is the appropriate use of PPE within the school during school day function, and the fact that PPE, protective equipment, namely a mask and a face shield and gloves, or frequent use of hand sanitizer, is tremendously effective in preventing the spread of COVID. It reduces the risk somewhat on the order of tenfold. So the main concern to the staff is really based on the age of the staff member. We know that as age increases for every 5-year interval, the risk of having a bad outcome from COVID, particularly when you pass the age of 50, goes up dramatically. So those are really the critical factors. We also know, because there's lots of schools that have chosen never to go virtual or have been virtual for only a small fraction of the epidemic, that schools, particularly for children K through 8, don't seem to generate epidemics. Now, if you look at, it's interesting, if you look at universities, because the CDC did this study, towns where there's a university that opened physically, 50% more COVID than towns that had a university and the university stayed virtual. They did the same study for K through 8, no difference. We don't really understand why biologically that's the case, or whether it's some kind of psychological or sociological phenomena about what university students do that elementary students don't do. But that's the data. No increase in cases in counties that opened up their schools compared to counties that kept their schools closed. And I can try to find the article and share that when I have a free moment.
Dr. Cascone, I'd like to piggyback on that, if I may. What Dr. Joseph said is really interesting, because as a physician who takes care of multiple school districts and universities, that's exactly what I've seen clinically. The schools that have opened, there have been some where they've had some clusters among staff, initially, but once they were up and running, they were fine. We haven't seen an increase. And looking at different school districts, ones that are open and ones that aren't, I'm seeing about the same level of infection passing in adults, and most of them are not related to the school. It's related to what they're doing socially or on the weekends. And I'd like to bring that back to what we were talking about before with the metrics we're using. When you were asking about how do we like rationalize that disconnect, and I think you need to take into account that there are differences locally between different towns and different counties and different populations of and practices in the school districts, as well as what's happening universally. Like the fact that our numbers are pretty stable right now when compared to the county, when we're 2 weeks after all the holidays, I think is a very good sign. I think in contrast to when we were back, when we held off in the fall, there was an uptick and we didn't know what was going to happen. We had all these things coming up that would most likely increase the rate of infection. Now we're in a whole different situation. We're coming out of that. The numbers are relatively low and we're not expecting anything like that coming up soon. In fact, hopefully they'll get better with the vaccine rollout and more people will be vaccinated and we'll go in an even better direction. But just to go back also to Dr. Schertz, what he was saying, I am seeing a great deal of psychological trauma in teachers, parents, and students. And I'm hearing the complaints. And one of the things I would ask our infectious disease experts, if they could address a little bit more, if you don't mind me, Dr. Cascone, posing this question, is the relative risk to staff members if they're washing their hands, they're maintaining social distancing, and we have classroom sizes that are a fraction of what they were initially, and everybody's kept apart, nobody's close together, even down to which way people are walking in the hallways. If we could talk about how that risk is low, and also maybe make the point that teachers are not going into a hospital. This is a school. Unlike Dr. Josephs, who's going into a hospital ward where he's treating multiple COVID patients and putting himself at risk, he's remained relatively healthy by using the personal protective gear. Isn't it that much better for going into a controlled environment where we're trying to keep the COVID cases out? I turn it back to you.
So any, Dr. Chasse, Dr. Josephs, if you wanted to, and I'm glad you've mentioned that because I did want to kind of delve a little bit into this idea of transmission in schools, right? There seems to be a bit of a kind of a dual view on that, right? You see some articles that talk about outbreaks in schools. You have other articles and research that talk about that transmission is not happening predominantly in schools. What is the truth? Where does the truth lie on that question?
And I just wanted to jump in to add to what Dr. Kelly said in regards to what we were looking at in the early fall. We also didn't know what was going to happen with the flu season and how many people were going to get the flu vaccine.
Mm-hmm.
And so now, the flu, we're not over the entire flu season, but we're midway through it. And so as we're, one of the things that we were really concerned about with the second wave was that synergy if people were hospitalized because of flu symptom, because of the influenza virus, as well as the burden on hospitals from people getting COVID in a second wave. So I think that was another thing that we were looking at and thinking about being more cautious. And now we're kind of over that hump for the most part.
Thank you, Dr. Campbell. So that again,
the risk is low for the teachers at school. SARS-CoV-2 is primarily transmitted by droplets, respiratory droplets within 6 feet. We've got 25% capacity. We have our children more than 6 feet apart, plus they're wearing PPE. It's very, very, very rare cases where it is spread in smaller respiratory droplets. We're talking about something where it's inside a closed environment. We have good ventilation. So the majority of the spread is going to be, I mean, even contact is very low, but we shouldn't have to worry about contact because of the fact that we have really good hygiene. In between, when the children are not there, our desks are being cleaned, and our, everything within the school classroom is being cleaned. I know I asked Dr. Cascone on one of our previous meetings leading up to this about the hygiene, what they've implemented, and they have, and the parents should know that the cleaning and disinfectant, the hand hygiene, this is all being pushed and promoted in school, which again drops that risk significantly. But again, the biggest thing that we need to know, referring back to the initial question about the teacher's risk, it is extremely low because of SARS-CoV-2 being spread mainly by respiratory droplets. It's within 6 feet, so we're separated. And yes, teachers do have to go towards their children and speak with them. One, it's a small amount of time. You're not going to be sitting with that student for a long period of time. Again, and how this particular disease spreads, if you're next to them for a very short period of time and both of you have your PPE on, it's going to reduce that risk significantly.
Dr. Josephs, anything you wanted to add?
Sure. So I just pulled up the data. So the state right now is reporting 121 outbreaks affecting 600 individuals from schools in the state since they started tracking them. That means that on average, there's 5 infections for every outbreak. If you do the division, that's really not an outbreak if you're talking about infectious disease epidemiology. And the reason that many of them have happened, and this is what I think Dr. Kelly was referencing, is that it's actually due to a flaw in the testing that we have right now. Unfortunately, what happens when you reopen a school often, and some districts have done this, is they've tried to test everybody before reopening. But the test is not sufficiently accurate nor designed to do that, actually. It's designed to detect infection in symptomatic individuals. So when you test asymptomatic people to reopen your school, you need to maybe test people 3 or 4 times to get accurate data about who's infected. So my suspicion is that the test just hasn't picked up everybody. School has reopened. There's been a small outbreak. Those people get quarantined and retested in accordance with the guidance from the New Jersey State Board of Education. As you know, Dr. Cascone, as well as I do, they have a very long document that outlines the rules around that. And then everybody else truly is negative, and school proceeds, on its regular path. There's no way to stop transmission completely in the building. That would be short of everybody being in gear that the school can't acquire. So there are ways to do it. Everybody could wear a biohazard suit like you see in movies like Outbreak. Those are much more effective than masks, but they cost thousands of dollars. It's just not feasible. So, with the standard surgical masks, which cost, pennies basically, a little more now because of the demand, but basically pennies, you reduce transmission a tremendous amount. If both parties are masked, it's something on the order of a 95% reduction in transmission. More or less.
Thank you.
Plus, it's not TB, measles, or chickenpox. I mean, it's not something that's going to be transmitted that way. So that's definitely with the larger droplet size.
Got it. So we have about 8 minutes left, and just for the audience, we had kind of intended that the first hour would be kind of a moderated Q&A, and then the second hour of the program, we would open it up to public questions. But I just want to close with some questions about vaccines. One of kind of the suggestions, and understandably so, right? You can understand why, a teacher who's fearful of coming into the building, and as the vaccines are the vaccines are here, just in terms of a couple things. One is, and maybe this is more of a local DOH question, is, what's up with the vaccine? What's up with the supply chain? What's, like, what's that effort look like right now? Where are we in terms of the queue? I know that educators are 1B, or even at 1B. Can somebody talk to me a little bit? And realistically, when you think about what would that timeline look like, as much as you could kind of estimate, considering all those factors, a time by which we could reasonably say that all of our teachers who wanted to be vaccinated would be, and with the requisite time in between and the week following it for the immunity.
So I definitely could provide some answers to some of those questions. And so, number one, we are in the 1B phase, and initially the state's efforts were focused on healthcare workers. And the way that, the thinking behind that was to look at people who had the highest risk of exposure, but also the highest risk of transmitting to others. So for folks like Dr. Josephs and myself who work in the hospitals, not only may we be encountering patients with infection, but then we have to go and see other patients. And so it's not only our risk of exposure, but also the risk of exposing others.
Mm-hmm.
And so unfortunately, when the vaccine was produced, we knew that there was not going to be enough vaccine produced for everybody. And so the state has an allocation that they get. And, the state did some focus groups, surveys, different things to try to find out how many people were going to take the vaccine hesitancy, questions about that. So there is a lot of work being done on the Department of Health's side to answer a lot of those questions. But I think the long and the short of the story is that there are more people who are interested in getting vaccinated than there is vaccine available. And so while teachers are in 1B, the problem is that now the demand is more than the supply, even amongst the various groups. And so as they tried to roll it out for the first month for just the 1A people, and not everybody who was eligible to get the vaccine wanted to get the vaccine at that point. And the state made the decision to start opening it up to the 1B people. Now people who are in 1A could still get the vaccine, but I think the major issue is that there's more of a demand than there is a supply. And what there is, people can register through the New Jersey vaccine immunization site and to make their desire known to get the vaccine. And then when their group is when it's up, their group is available, when it's their time, they're going to be notified. But they are doing a lot of work, particularly on making sure that the vulnerable populations are folks in long-term care facilities, healthcare workers, frontline essential workers, the folks who we need to be in the supermarkets. We need to produce the PPE that we need to keep ourselves safe, to make sure that utility workers, all of those folks. I just want to also say that the state also made an effort to make sure that when we think about people who work in various industries, we want to make sure that people who come to the front of the line are the people who are front facing with the public, because again, they are the people who are at the highest risk.
Thank you, Dr. Campbell. From our local DOH folks, I know that you have a lot of contact with the county, and I know just having had a couple of brief conversations with you, anything you want to add on that, and what you're seeing kind of boots on the ground in West Orange and Essex County, and Dr. Kelly as well, anything you might lend on that?
Dr. Cascone, what I'm seeing right now and what I'm hearing is we have many senior citizens that are still wanting the vaccine and not getting it. They're trying to register any way they can. We're trying to help them register. So we're really not anywhere near done with vaccinating senior citizens yet. We're not finished or even started vaccinating our homebound population that either is homebound immobily or disabled. And teachers as a group, I mean, if a teacher individually meets the qualifications of some of the illnesses that are listed, that makes them compromised, they can register just like any other resident can register because they have those diseases in it, you know, that the state has listed that makes you eligible for the vaccine. I feel right now there's not enough vaccine coming out. I've tried myself to get the vaccine in the West Orange Health Department, but right now I'm not able to get it. It's going solely to the county. And I know that, you know, they're trying to do the best job they can in those sites, but, you know, this vaccine is going to open up more and more in different locations throughout the county, throughout West Orange. Hospitals are going to be having clinics at hospitals, and pharmacies have it. ShopRite's getting it. I mean, number of places are getting it. I just think the amount of vaccine that's coming out is not enough for the demand. I don't think the problem is that we don't have enough vaccinators. I think we have them. We need more vaccine, and maybe in the near future we'll get that. But right now it's being really kind of doled out in a way that we want to say we can do X amount a day. We can do more. We can do a lot of things, but we can't do it unless we have the vaccine. So we're kind of ruled by what the state is saying because they're the ones doling the vaccine out. So if they'll give us more, we'll try to use it.
Understood. So it's you know, is it safe to say that it's a months, not weeks? Dr. Josephs?
Yeah, so it's a pure production problem, really, more than anything. Pfizer and Moderna can make X number of doses a week, and those doses are all pledged to various people right now. And it's not just the United States. Israel, for example, has bought up a large supply, just to name one country. And so right now, the last numbers I saw was that New Jersey is receiving roughly 100,000 doses of vaccine a week. We have, according to the governor's estimate, 4.7 million people he would like to vaccinate. If you divide 4.7 million by 100,000, you get 47 weeks. So it's nearly a year at the current production rates of Pfizer and Moderna's vaccine. And that means vaccinating everybody once. And these two vaccines, it's a 2-shot regimen. So we're many months away. Now, if President Biden chooses to do things to change the manufacturing chain to help Pfizer and Moderna produce more, even that's going to take a few months. You can't just buy these kind of refrigerators and manufacturing facilities off the shelf, even if he chose to invoke the Wartime Production Act to try to move things along more quickly. I think the reason for optimism is to see what Johnson & Johnson says at the end of the month. So Johnson & Johnson at the end of the month will release data from their what's called phase 3 clinical trial, meaning the trial done to really see if the vaccine is efficacious. They have data that it produces an immune response so far, which is a good sign, but it's no guarantee. And Johnson & Johnson probably has several million doses ready to go, assuming it works. Although they too are behind in production, and I don't know who's going to get them. And maybe Dr. Campbell has some insight because I see her waving her hand at me.
Oh, no, I was just saying that the advantage is that it's only one shot as opposed to what we have now. I mean, I think that's going to be the big push because right now what's happening is people are getting the first dose and then the second dose is pledged. But with the Johnson & Johnson vaccine, it's one dose and it's producing the same, looks like it's going to produce the same immunity. So that will be an advantage.
And the other thing that I want to jump on that and say with the The Moderna can be stored in a warmer temperature. The Pfizer vaccine has to be negative 94 degrees. There are a lot of places that can't give the Pfizer because they can't store them. I mean, think about where we're giving the vaccines right now. We have no place, you know, the Kmart, Sears, and Livingston to store it. So, you know, as they find other places to store it, we may be able to get more, but that again of the Pfizer vaccine. The Pfizer is also only 21 days, you know, 3 weeks between day 0 to the second vaccine. Whereas the Moderna one is 28 days. That gives an extra week. So that's just another thought in that.
I have one final question about the vaccine, and then I'm going to turn it over to our moderator and open up the public Q&A. Is this a one-time vaccine? In other words, is this more like the flu vaccine, where it's something that would need to be administered annually, or is it like, you know, measles and mumps, where you get it one and you're done? And the reason I'm asking that is only because, you know, if we predicate return, or we predicate school safety on vaccination for the COVID-19 virus, then this is an annual endeavor. So I'm just curious about that.
No, it's an excellent question. I'll jump in and just say that it's one of the questions that we don't completely know the answer to, because we don't have the long-term data. The data that we have from the trials is short-term data in regards to adverse reactions. And so it's going to take some time for us to know how long the immunity from the vaccine is going to last.
The other thing I'll say is that there is data, there's 2 pieces of data here that's helpful, but doesn't give us an exact answer, because so in the first SARS, which people may remember from about 15 years ago with outbreaks in China and Toronto, there are some people who still have immunity, and we're 15 years later. So those people would not need to be revaccinated. And it may be that this—
Which is the coronavirus, you might want to
yes.
tell them too.
Yeah, sorry, yes, which is a very similar virus to what we're dealing with now. The longest out we have anybody immune to the current COVID is 9 months. So England has an ongoing study of nurses who were infected in the hospital very early on, and about half of them, at least, are still immune now. So some people may be able to not get revaccinated. Some people may. Hard to know. And we may have to roll out a different kind of program to test people, and that's going to be complicated. There's no vaccine we do like that right now. We just give you another booster. We don't check levels for the most part.
Got you. All right. Well, I want to thank everyone. I'm interested in I think this has been an extremely informative conversation, and I'm interested in hearing what kind of questions we have from our public. I would just, before I turn it over to Mrs. Tomasi, I just would like to try and frame out this next portion of the meeting. You know, each speaker will have a minute, you know, and we've given a minute in order that you have some time to kind of frame out your question and then ask a question. And we're hoping that the questions that come our way, and, you know, I'm the moderator, you know, we're really hoping that questions that come our way are questions that are geared towards public health, that are geared towards mental health, you know, epidemiology. As you have me every day, I'm not going anywhere for the time being. So you have a question for me, you know where to find. But these folks here, you know, in many cases, you know, not necessarily going to have access to. So you have this opportunity, and we hope that you take advantage of it to ask questions in the spirit of whether it's busting myths or clarifying or, you know, gathering reassurance or gathering clarity. We hope that's how we can approach it. So with that, Mrs. Tomasi, I would just turn it over to you and ask for you to just provide some guidance to the attendees on how they would go about it.
Okay. I am going to share the screen now. As opposed to Board of Ed meetings, as Dr. Cascone said, we're allotting 1 minute for questions. So you'll see a 1 minute timer. Dr. C, do you need to have people identify themselves by name, or are you taking questions anonymously? What's your preference?
I would say that it can be either way. If people feel comfortable recognizing themselves, they can, and if they'd rather remain anonymous, I'm okay with that too.
Okay, so I will recognize those who raise their hand in the chat. And let me start by calling on Mary Stevens. Mary Stevens, can you hear me? Are you there?
Yeah.
Okay.
Yes, it's actually Sonny Stevens on behalf of Mary Stevens.
Thank you.
My only question, or our only question is, I know we are rushing to open up on Monday, and in light of the current struggle with vaccination and lack of vaccine, it would at least give the parents a little confidence if the teachers are all vaccinated, and unfortunately, we are not there. So, and in light of the change of the administration, maybe we should maybe give them a chance for a week or two so that we could get some clarity as to if we are going to get more allocation of vaccines or not before we rush into reopening. And again, we do understand all the data that we have in support of schools and universities. That's all the question I have.
Okay, thank you. Would you like to address that, Dr. Cascone, or do you want to hear some more questions?
Well, let's keep going with questions.
Okay. The next person who I will recognize is Elizabeth Redwine.
Hi, thank you so much, everyone. I'm going to try to talk as fast as I can. I just want to thank everyone, and especially the mental health piece by Dr. Schertz, because my sister just told me I could tell this story, went back to work as a counselor in a high school on Tuesday in New Hampshire, came home, got a call from the school nurse that she'd been exposed to someone with COVID. She's now quarantining. She has 3 young kids in the school system who they had decided to have go remote because of their community spread, which is actually lower than ours. So, you know, I just want us to also focus on, I don't teach in the school system, but having seen what my sister went through, I just want to acknowledge that there's a lot of mental health concerns here. It's for teachers and administrators and their family as well, and for all of you and everyone on the Board of Ed. So I just wanted to kind of share that story, that it was really terrifying for her and continues to be. And luckily she has no symptoms so far, and it's been a few days. Hopefully she'll be okay. But wow, what a thing for a school counselor to go through. And unfortunately, I think we need to be prepared for that. And I'm just wondering if there's any kind of planning for how to deal with that issue with teachers, because it's a big school system, and unfortunately the likelihood is that something like this will happen. This was her first day back. So it was, from what you're saying, that sounds surprising, but that's my only experience is what she went through.
Ms. Redwine, I just want to ask a follow-up question.
Mhm.
In terms of the district's response. Is that question coming from a logistics place?
Yeah.
Yeah.
That's right, Dr. Cascone. So just like I have to admit, I hadn't thought about any of this because my kids are older. And so if I have to quarantine, like thankfully I haven't had to, but they're old enough that but her kids are young. So I'm just like, and this might be a tough one to answer, but we do have to kind of play out bad scenarios, unfortunately, I think, much as we would like not to. And again, I'm not an epidemiologist, and I'm just seeing what she and her husband are going through, trying to quarantine her away from little kids after exposure. So
Yeah,
I don't know if there can be stipends for takeout food. I have no idea how this would work, but or counseling for teachers and administrators if they do end up in that situation. Okay, go ahead. Sorry, that's my minute.
No, that's okay. No, so right. So I'm hearing it. I think there's 2 parts to the question. I think I would ask. I'm going to ask Dr. Schertz to just follow up. I think there's 2 parts to that question. One is kind of a nuts and bolts logistics question about when we open, what we've seen in other districts that are open is that from time to time, Dr. Kelly could probably speak to that in great detail. Either classes or schools have to close for a period of time, or schools don't have to close, but teachers are quarantined. And I think what I've seen from the towns and the neighboring areas that have been open is that yes, staffing can be a challenge, but it's not one that has frequently resulted in a necessity to shut down a school because of lack of staff. That being said, and I want to be very clear on this as we move forward, when we move forward with this plan, is it's not a damn the torpedoes, we're going full steam ahead and we're never looking back, right? The overall sustainability of this effort will be evaluated on a day-to-day basis. And whether I'm talking about sustainability from, just by virtue of staffing, or the inconsistency created by closures is so great that it becomes the law of diminishing returns. Those are things which will be looked at very closely. And if we need to reverse course because of that, we can. I think the mental health side is that's a harder question to answer, and it's one that's probably more out of my depth. How do we support our staff? Dr. Schurz, that's kind of what you do, and I know that we have access to the Teacher Coach platform. Do you want to? And I'm looking to learn from your answer as well. Is maybe can you speak to maybe districts that you would consider that exemplify best practices in the area of social, emotional, mental support for teachers, what that looks like?
I'd be happy to. My first reaction, though, is that the first two questions, I'm so impressed with how thoughtful the questions were worded. They were curious, they were exploratory. There's no accusation, there's no concrete beliefs. There's a recognition that we're all in this together, and that this has to be a community effort, and that it can't fragment the community, because that would be a tragedy on top of existing tragedies. So I'm just so appreciative of the folks in your community so far for how this discussion has begun. It's just so wonderful. In terms of the approach to dealing with mental health, I really want to applaud Dr. Cascone and the board, because there are very few districts throughout the country who have put such thought into preparing their faculty and their community. I've done surveys with school district administrators, and the preponderance of them say we recognize social, emotional, and mental health is important, but in reality, we haven't had the time because we're up to our elbows in other crises and logistics. Dr. Cascone is also working around the clock and has the same burdens, but made sure to put something in place for mental health. So I think that's absolutely wonderful. And it's just the first step. As we go through this and as we learn how the trauma and the stress are manifesting, especially with the continuous changes, we'll be able to do more strategic planning about what kind of help may be needed.
And Dr. Schurz, and I want to be reflective, because on this one, I just, for any staff members that are on, and while I'm appreciative of Dr. Schurz's compliments, and I think we've done some good things. I think it's about consistency, right? And being reflective. I think that and it's interesting because I had a wonderful student at the high school who's created a student mental health advocacy group. And they've recently presented to the high school. And she reached out to me and she said, Dr. Cascone, what more can we do to support the mental health of teachers? I love our kids. And I was like, you're right. And so I think looking reflectively, and whether it's periodic things or putting structures in place in the schools, we need to do better, and we need to be more consistent in availing those resources to teachers. So I'm making note of that, and we'll get working on that in the short term. And I'd love to collaborate with you on it as well, Dr. Schurz. Okay, Ms. Tomasi.
Okay, the next person with their hand up is Rachel Keene.
Hi, can you hear me?
Yes, we can.
Hi. So I just had a question about the positivity rate calculation. I was wondering if routinely done tests are counted toward the total number for the negative tests, like for example, people who get tested for school and work, or patients that are tested, for admission to the hospital. Does that get prioritized in the, in the numbers, or does that come a little bit later? And do we usually get all those numbers in our total negative PCR tests?
Anyone want to take a stab at that?
Yeah, I'll take that, Doc. So basically, the way that the process goes is we take the numbers daily from the communicable disease registry, which the negative numbers are a cumulative number. We don't know if they've been tested for scheduled surgeries or dentist appointments, or it's not drilled down that far, unfortunately.
And thank you, Nick. On a more, any of the other anyone else on the panel want to expand on that, just on a more, not necessarily on a local level, but just kind of in an overall professional level, Dr. Campbell?
Yeah, I was just going to add to that. The difficulty is that people can be tested in so many different places. And as you can imagine, somebody may live in West Orange, but they get tested in New York. So there are so many factors. I also just wanted to touch on the prior two questions, and I agree that I wanted to just empathize and say that, I'm very appreciative of the thoughtful questions. I don't think right now, and I don't see for the foreseeable future, that teachers would be mandated to be vaccinated, because as was mentioned, right now, we don't have enough vaccine. New Jersey is a state of 9 million people. We only have 100,000 doses that are allotted weekly. So we're not at a place, plus I think there's so many other issues. And while we may want teachers to be vaccinated, and I certainly hope as a physician that some teachers may consider that, I don't think that we're anywhere near a place where anybody can mandate that people get vaccinated. Even in our hospitals, we're not mandating vaccines to employees. So I just wanted to mention that. And I am, as well as being a physician, I'm also a parent of a West Orange Elementary student. And so I am very empathetic. And I think we all need to be empathetic because we're all in different places with this pandemic. And we just have to be understanding of each other's situations. And so I think if we go forward with the opening up of schools, which I do hope that will continue to happen, there are going to be these times when somebody's going to be positive. It's happening in the hospitals. I wish that we could get to a point where we would say there's no risk for anybody, but it's not possible. We're going shopping, we're going, we're interacting with the community. We're going to different places. There are people eating out, and so it is going to happen and we have to be prepared. But I've been very impressed in my own elementary school, listening to the plans that are in place in terms of temperature checks, in terms of social distancing. I mean, these are very well thought out plans. And I just want to be respectful for those people who feel comfortable, knowing that the plans have been well thought out and will be implemented, feeling safe. And if people are not ready, then that's okay too. They have the option of opting out and, waiting and see how things go.
I could just share a couple of quick things. First, I double checked the state guidance just to be certain. All negative tests are reported regardless of why they were done or what type of test was done. They don't always show up quite so cleanly on the state website because state website sometimes a little bulky in this regard, but the state does at least break it down by PCR versus antigen testing. What I just want to share for 2 minutes, if you'll permit me, Dr. Cascone, is I was actually exposed and contracted COVID through an encounter in the hospital very early on during the pandemic through a failure of my PPE. While I was in a patient's room, the straps holding my mask broke. And so therefore I was in the room inhaling, the same air and droplets of the patient. It's a very frightening moment, of course, when I felt the mask sort of fall off my face, and I was like, oh boy, what's going on here? But the antidote to that is two things. One, I can't obligate you in, but I would encourage the district to think about what its response would be if somebody's exposed, and getting them to somebody like Dr. Schurz or a counselor to deal with the, emotion of having something like that happen. But two, the other antidote is the data and the factual science of the matter, which is that thankfully COVID is rarely a serious infection for the vast majority of people who get it. Again, if you're 75, 80, that's a different story, but I'm 37. So, I just looked at the data and I said, okay, I know what I have to do. I know I have to quarantine and check my temperature and all these things. And, we're just going to see how it plays out. So I certainly hear both sides of it. And I applaud the district for the work that it sounds like that it's already been done with Dr. Schurz to explore this, and that I think is going to continue to go forward. I deal with a lot of school districts, and I think y'all are very well prepared compared to many with whom I've spoken so far during the pandemic.
Okay, the next speaker is Bonnie Pomeroy.
Hi, good evening. I'm a teacher at Edison Middle School. And first, I just want to commend you, Dr. Cascone, for all the hard work that you have done during this crisis. And I thank you for keeping us safe all this time. So we just had a memorial for over 400,000 people that have died so far of COVID. So I will put it simply. I don't want to die. I don't want my students or members of their families to die. I don't want my colleagues to die. I don't want members of my family to die. So what reassurances can you give us that none of us will die if we go back to school before everyone is vaccinated?
This is, and I'll take it just from a human and superintendent side, and then, I'll just offer it up to, the group. I think I would kind of draw a tangent to Dr. Joseph's last commentary in terms of looking at the data, and, it's a balance, right? It is absolutely a balance. And as it's been discussed by the medical professionals, there are people who by virtue of their age and pre-existing conditions are at a high risk, and heard Dr. Joseph speak about, and for whom they might be at high risk, and but if you're not falling into one of those categories. And I don't know, Dr. Joseph, if you have any kind of statistical comparisons, relative to, mortality rates, or, in other words, if you fall into a non-risk group, the likelihood as compared to, I don't know if you have any kind of data which might help allay some of that fear.
Yeah, so I can pull up some of that data. I want to tackle one very specific point, though, before I do that, which is that even once everybody is vaccinated, unfortunately, the vaccine does not have a 100% efficacy rate. To my knowledge, there's no vaccine that has that efficacy rate, but certainly not the COVID vaccine. The best number from the clinical trial was 95%. So that means still 5 out of every 100 teachers, even after vaccine, will be at risk to acquire, well, not just that, the vaccine is actually studied for preventing severe COVID, not the acquisition of COVID. So people will still be at risk to get COVID. What I can say by comparison about the risk of passing away is that the US military, which is people between generally 18 and 50, has had 200,000 cases during the pandemic and has had 200 deaths. So yes, some members of the military have died. I don't know who those individuals are and whether they had pre-existing conditions, but in a young, relatively healthy cohort, dying of COVID is an extremely rare occurrence. Again, it's not zero, but it's quite small. Just to give people some overall perspective, so here's the top 10 causes of death in the United States in any given year.
You want me to give you screen share, Tanya? Can you give Dr. Joseph screen sharing?
Sure. Let's see. I think you should be able to. There we go.
Yeah. So here's a table from 2018. I think this is from CDC, United States data. So here's what people are dying of in the United States: heart disease, malignant neoplasms, that means cancer, accidents, respiratory disease that's not cancer itself, but it's probably related to smoking, strokes. So, you know, COVID's number 4, that's true. You know, if these data are about right for 2020 also, which they probably are. But that's really due to the elderly. So again, if you're a teacher who's in your 70s and you happen to have malignancy, I think you have to have a discussion with Dr. Cascone about, or, you know, your principal about coming back to work. But if you're in your 30s or 40s, the data really suggests a very small risk from COVID. And I'm happy to share more data with Dr. Cascone to distribute, you know, when I can pull it up, not in real time.
Dr. Campbell?
Yeah, I mean, I just wanted to say, appreciate the question. And I think, Dr. Cascone, you can't give any assurances. I can't give any assurances. Dr. Josephs cannot give any assurances. Dr. Kelly cannot give any assurances that anybody going back to school is not going to die from COVID, because you don't only get COVID from your occupational exposure. And as was mentioned by Dr. Josephs, unfortunately, the vaccine, I mean, we want the vaccine and we want as many people to get the vaccine, but that is not the end all be all. We're still going to need to do a lot of other things. So unfortunately, the answer to your question is that none of us are going to be able to assure that even once everyone gets vaccinated, that nobody's going to die from COVID. That's just not a possibility.
Dr. Schurz, thank you, Drs. Joseph and Campbell. Dr. Schurz, that's a tough. I mean, I'm hearing it, and I don't have the. That's a question I think that perhaps you'd be best equipped to answer, because that's a tough reality. But you know, the reality of moving forward as a society, you know, we're balancing it with that, right? Because we can't stay frozen forever. And I'd ask you to answer that from a mental health standpoint, but then I would like to pivot back to the medicine side and say, you know, people say, well, we're always going to be in a world with COVID. So doctors, I want you to kind of think on that. Because we have this idea that, you know, we're going to reach an endpoint with this, and whether it's the vaccine, and then at that point in time, we're all going to feel safe again doing what. But I'd like you to think on that question as, you know, what does this look like next year and beyond as it relates to COVID? But Dr. Schurz, we just had it. What do you say? What do you say to that? Because that's a tough, it's a tough situation. It's a tough reality to reconcile, isn't it?
Teachers and educators across the country have been feeling, well before the pandemic, marginalized, unimportant, not well respected. And now they're in a position where they're literally putting their health in danger, and their anxiety, their stress level is being dramatically increased by being expected to go back. And it's terribly unfortunate that our most important professionals, and I do believe our educators are the most important professionals on the planet, are not recognized nearly enough for the sacrifices that they make. And this is a great opportunity for the parents in the community to come together to send messages of encouraging messages and appreciative messages, and really acknowledge that teachers have always made tremendous sacrifices, but now the sacrifices are beyond what anybody could ever imagine. And you need our devotion and our appreciation. And while that doesn't abate the fear and the constant threat that you're going to be experiencing, it at least lets you know that you're being acknowledged for what you're doing.
Thank you, Dr. Schertz.
The next person who is up is Lauren Weinshank.
Hi, thank you for having this meeting. It was so informative. And I really want to thank you for looking at the mental health aspect. I think everybody in this pandemic has suffered some sort of mental health issue. I work at the local hospital. My office was closed up until June, and we went back to work in June. I would say I'm in an outpatient department of about 75 people, and we wear cloth surgical masks. There has been about 8 cases of COVID within the department. All they came from outside. Nobody got sick at work, and there was actually no spread at work. This is wearing simple surgical masks. We do not wear eye protection. I'm a social worker, and we wash our hands. So when I think about going back to school, I'm imagining the teachers in masks, the children in masks with distancing. And I know you touched upon this, but if you could really talk about the community spread, like going out to dinner with friends or, socializing versus what happens in the school, and dispel this myth that school is the place of transmission. Because in my experience at work, the office wasn't the place of transmission. Every case was gained from family gatherings, unfortunately, outside of work. And really, thank you again so much for having this. I think it's a wonderful conversation.
Dr. Josephs, I saw you nodding your head like you wanted to take a whack at that. You want to go for it?
The short answer is schools are not the place of transmission because, as you said, masks work. Where do you take off your mask? Nobody wears their mask at home. I've yet to meet such a person. Even people who are quarantining, I have to remind them to wear their mask. I just had a patient. He's a doctor. He got exposed accidentally. I had to remind him, no eating with your wife. He was like, oh, right, yeah, a time without a mask. So at home is really where it happens. As Dr. Schertz points out, we're social creatures. A mask is a frustrating thing. Your voice is muffled and your facial expressions are eliminated. It's much harder to communicate with somebody wearing a mask, so they come off. Anybody want to see an example of this? Watch the football game this Sunday and watch how many times the coach pulls his mask down because he wants to talk to his team. The mask doesn't prevent that, but yet the need to express oneself overwhelms, the mask comes down. And I can assure you that the fines that this coach will be hit with for doing that are quite substantial. So it still doesn't stop it. So most of the transmission is taking place at home. Outdoor dining, there's perhaps a little bit. Indoor dining is a very complicated question that I don't want to really get into. Suffice to say, it's very complicated because it has to do with the air handling system of the space in the restaurant. So it's basically as specific as any restaurant is in its design. Same thing with an airplane, becomes very specific. But yes, the masks work and work extremely, extremely well.
I want to add to that with the mask. We're talking about different kinds of masks right now. The main CDC WHO recommendation is cloth, non-valve, multi-layer mask that's washed regularly. A lot of times people think they get, fancy schmancy masks and, get N95s or different types of masks that they've seen on Wish or Amazon or what have you. But again, having the non-valved and the fabric multi-layer, as long as you do make sure you wash it. Hygiene for masks is just as important as hygiene for hands. And that's something that people tend to forget. So I do want to add that as well.
Thank you, Dr. Johnson.
And I just wanted to add that that was a really important question. And so what it reminds us is that even as kids return to school, what happens on our weekends is really just as important, as anything else, because our socializing, our getting together is usually what happens in the evenings and on the weekends.
And I appreciate you saying that, Dr. Campbell. And I think I'd like to just kind of editorialize here a little bit that, and this, I kind of spoke to this in my last correspondence, is that I talked about the idea of being kind of a divided populace and embarking upon a complex endeavor. And that's never a good formula. And I think that the success of this is going to require, the collective efforts and the unified efforts of the community. And I think specifically as it relates to how and it's tough because, we have that, kind of that COVID fatigue but I think this is really crucial that it must be a community-wide pact, that this is at top of mind always, whether it's who our kids are interacting with or who we're having in our homes, that has to be the corollary to us opening up schools in the community. And for all those who have, robustly petitioned for it, and I appreciate it, there must also be that pact that we're going to honor in terms of the way we're handling ourselves out of school and our families. Ms. Tomasi?
The next speaker is Kabira Myers. If you could unmute.
Yes, hi. Good evening, everyone. And Dr. Cascone, thank you so much for putting together this incredible panel. I am very, very, I've been very, very educated tonight. So panel, I'm not a medical doctor. So if I ask, or if my question sounds silly, let me apologize in advance. But how will we track the effectiveness of the vaccine once it's taken en masse in our community? How do we know that it's doing what it's supposed to do after, our community members, after we've taken it? I mean, do we need to knowingly have close contact with someone who's COVID positive to know whether or not the vaccine is doing its thing? So how will we keep track of that in the future? And then the other thing is, I'm also an advocate for the district allowing our teachers to get the vaccine before returning to school and allowing the vaccine to incubate in the bodies of our school teachers who take the vaccine before returning. So those are, so that's my question, and that's my little opinion for the night. Thank you so much for your time.
Should I move on, or would you like to address that?
So just so I understand, the question is what the school district's role will be in the ensuring that folks are vaccinated. Did I hear that correctly?
So my question was, if in fact the school district allows its teachers to get vaccinated before requiring them to return to school, will it give them that time, that reported 30-day time frame for the vaccination to run its course and become effective, you know, so in other
Got it.
words.
Yeah, I understand.
Yeah, okay.
Well, at this time, at this present time, we're not presently offering an accommodation for people for staff members to work remotely until such time that they had the vaccine. I think it's important. They can work remotely in the case of their quarantine and things of that nature. But I think it's important to realize is that that if a teacher is working at home, that requires us to have really just a daily substitute in the classroom. And we have students that are coming in for a limited number of days for the benefit of having that on-site instruction, and they're receiving that instruction from, actually they really wouldn't be receiving instruction at all, from the daily substitute. So it's tricky. I will tell you that I am looking to revisit with our HR department in cases where we have people in high risk categories, and evaluating situations on a case-by-case basis. That wasn't something, all this has kind of happened and come on recently, but that is something that I would consider exploring with the HR office, for folks who want to come back and feel like if they were vaccinated, they would, and are in a high risk category. That is something I think that we could begin to entertain. And in answer to your question, yes, it would be for that time frame, cumulative time frame between doses.
Okay, the next speaker is David Leach.
Hello, can you hear me?
Yes, we can.
Hi, so my name is David Leach. I have 3 questions. So my first question is, I know we can't stay frozen forever, but would opening school at a later date reduce individual risk, like say opening up in springtime? My second question is, I guess it's more pertaining to the data, because I was wondering if you could clarify a little bit more the 311 total tests used for positivity. Like I'm still not seeing exactly how the calculation went. And I was wondering also if alongside that maybe calculate daily positivity for yesterday. And additionally, if you look at the new case data, it also puts us in the red, according to both the CDC and the New Jersey Department of Health. And I was wondering if anybody looked at the new case data, because it does put us in the red. And my third question is, I was curious if anyone on the panel currently has kids attending public school. I was wondering if they were attending in person or remote. And thank you. That's my 3 questions.
Anyone want to go with that one first?
I think it's a matter of state and local district, and even sublocal to that, policy about trying to decide when to reopen and what's your cutoff for positivity rate in your community when you make that decision, given that it's going to be many months before the positivity rate is, say, 1%. And so the educators partly have to make a decision about the trade-offs between risk of illness in students and staff and all the many things that people have talked about that are problematic for the children when you're not in physical school. In terms of the positivity rate, I don't know if the daily data is downloadable from the CDRS website, and somebody else on the call can maybe help us out with that question. And I'll just speak for myself and say I don't have any children who are in public school.
I can't, I do have children in public school. So my son attends school in West Orange, and I am an essential worker, and my husband is also an essential worker. So we're not able to stay at home. And so we were fortunate. We usually get childcare from friends and family. And my mother is 80 years old. So, and she lives in New York City. So she's, in a high incidence area as well. And so we were fortunate enough, West Orange Community House has childcare set up actually at the Kelly School. And so on the days that I'm not able to work from home, I take my son to the Kelly School. They're set up in the gymnasium. They have the desks 6 feet apart. Every child is screened for symptoms and temperature upon entering the building. And they attend virtual school in the gymnasium. My son's biggest complaint is that the sandwiches, I don't know what's going on with the sandwiches, but there's some kind of humidity and it makes the bread wet and he just can't take it anymore. So he doesn't like the lunch. That's his biggest complaint. He really wishes, most of the kids that go there are several children that do attend the West Orange Community House care program, but they're from different schools. So he's getting to know them and has gotten to know them over the past few months, but they're not his classmates from his general elementary school. I just wanted to circle back in regards to the vaccine question. And so there is data about those questions that were asked. And sometimes people talk about what's called herd immunity. And so a certain percentage of the population needs to be vaccinated in order for us as a society to benefit from what's called herd immunity. There's been some varying numbers about what percentage of the population needs to be vaccinated in order to achieve herd immunity. I've heard 70%, I've heard 90%. The problem is, again, because we don't have enough vaccine, we're not at a point yet where 70% of New Jersey's population or even Essex County can be vaccinated so that we might benefit from that herd immunity. And then the last question in regards to the vaccine is that so there are studies that the studies that have been shown in the short-term follow-up, that's how the companies were able to get the authorization from the FDA, because they looked at people who got the vaccine versus people who did not get the vaccine. And they saw that there was that 95% efficacy amongst the people who got the vaccine against getting COVID. There's still the issue that if you get the vaccine, we still will need to wear a mask and wash hands, because even though we may not get sick from COVID, we still could potentially acquire COVID and then still pass it on to someone else. So again, the vaccines, they have their role, they're going to be helpful, but it's not going to be a panacea just yet.
And I would just add that, and I'm not sure what the relevance of the question is, but I'll answer it anyway. Which is, yes, I have 3 children, 2 high school, 1 middle school, and they have been in school hybrid since the beginning of the school year. Very similar program that we've planned out, and in fact, they're actually making plans to move into the next phase of their reopening, which would be more time in school for their kids. And it's a large district. It's probably about 16 to 18 schools, about 10,000 students, and there's some socioeconomic diversity on both sides of the town. So it's not it's not a homogeneous community per se. And they've been in. There have been occasions where they did close over the course of the holidays and the week after the holidays. And there were one occasion for each of them where they had to close the school due to 2 unrelated cases. But other than that, they've been up and running and doing okay.
So Doc, as to the 311 number, that number is the total positive results received and the total negative results received over the last 7 days. I do have 2 children in the district. Early on, we were going to be remote, and we're thinking about changing that to in person at this point in time. Decision hasn't been made yet, but we're going to make it soon.
I'll just add, I actually have 2 children that are in middle school, but I live in West Orange. They're special needs, so they're out of district, and they've actually been in their private school in person. They were out for over the holidays because of the high rate in their private schools, actually in Passaic County, so they had a higher rate, and they've recently gone back to school. And I, as a mom, as an epidemiologist, as a doctor, with obviously taking their special needs and my psychological background into consideration, I looked at the exact same factors before considering sending them back in. And that's, again, the 2 things to add on to what we were talking about before, which is not just the community burden, but also the implementation of the mitigation strategies, and that their school was doing that just as our district here in West Orange is doing that. And so that's why, I feel comfortable there, leading to the question. I know it was about asking about our kids, and as parents, do we feel comfortable as well as professionals? And, yes, it's really based upon those 2 things. Knowing that, once the community burden is dropped and once the mitigation strategies are defined, and they are clearly defined, and they're all being put into place. And so I do feel comfortable as a parent and a professional.
Okay.
Mr. Mossy?
Yes, the next speaker is identified as Elizabeth. Elizabeth?
Hi, can you hear me?
Yes, we can.
Hi, my name is Elizabeth. I'm a teacher at the high school. I want to thank Dr. Cascone for having this, and all the professionals for being here tonight. Thank you so much. I am one of the co-chairs of the WOEA Health and Safety Committee. Our committee has conducted walkthroughs and found some rooms to have ventilation systems marked as functioning as per a 5-item checklist, but upon our inspection, the ventilation systems are not functioning properly. Members of our committee are concerned about the health and safety of their students. They're concerned about their own health and safety. My question is this: how will the district ensure the deficiencies we discovered, despite the certification of the 5-item checklist, will be addressed prior to staff and students returning to the buildings? Also, what procedures will be in place as we move forward into whenever we do return, that the ventilation systems will be functioning properly? Thank you so very much. Stay safe.
So, I'll address that. For the benefit of the 500 some odd people on the call, but I would also, Mrs. Kelleher, encourage you and Mr. Maniscalco and your health and safety colleagues to reach out to me. I mean, I've been available, I've been accessible, in our conversations, and I'm happy to continue to meet with you as I have been to collaboratively work through these issues. Obviously, taking on, the massive undertaking of evaluating our buildings and ensuring that every room was up to snuff was a monumental undertaking. I think it's also important to realize that, we have older units, and a unit that's working today may not necessarily be working tomorrow because the motor goes, because it's a motor from, 1965. Now, to talk about that a little bit, because the question will be, well, then what happens if the motor goes on Wednesday afternoon and kids are due back in class on Thursday? And so we've been working with principals to ensure that there are auxiliary instructional spaces where those classrooms could be moved in emergent circumstances until those remediations were made. I can tell you that the checklists and the walkthroughs, you know, they are, it is an everyday top of mind, top of agenda effort. We have a new buildings and grounds director that's here. I mean, Mr. Ziggy is here until the end of the week, at the end of the month, but Mr. Semino has come in, jumped in, you know, neck deep into that. We have a new business administrator, Mrs. Flowers, who oversees buildings and grounds. They've been doing walkthroughs as well. And what I've said to principals is, you know, if upon a walkthrough, you know, you identify, as I've said to staff too, in my emails to staff, and say, you know, be an advocate for yourself as well. And if you deem that the 5-point checklist, which was verified by our HVAC specialists, is not accurate, I want to know about it. And in fact, I've received emails directly from staff members, one as recently as this week, and I responded to that email with a copy to the both directors of buildings and grounds. The incoming director is just doing a transitional period with him, the business administrator, the high school principal, and the high school head custodian. And I said, whatever the staff member believes to be in the issue in this room, I want it looked into immediately. And I want to understand personally, is it an issue that can be repaired? And if it can be, it needs to be done yesterday. And if it's not something that can be repaired in advance of when we're asking high school staff to come in, which if we are to move forward consistently with our timeline would be the week of February 1st, then I need to know that as well, because we need to ensure that those staff members and the building principal are aware that the classroom needs to be temporarily relocated. So, you know, what do you need to do? Bring it to the attention of your building principal, and I can guarantee you it'll be brought to my attention, and I will put whatever staff and resources are necessary. But my understanding is that if there are any remaining issues, these are punch list items, and they are relatively few in nature, and we're working every day to make sure that we've cleaned any remaining issues up. But again, I'm happy to meet with the Health and Safety Committee and address any remaining issues and ensure that we're working through. And listen, you know, we also are doing ongoing work. You know, I know, you know, some folks in the Mount Pleasant neighborhood, you know, might have noted that, you know, we have workers there, and we do, because while we have temporary solutions for ensuring that we have fresh air intake into those rooms, which is to manually open the dampers, we are also contemporaneously bringing in vendors to install automated controls into that. Now, we've been able to get in there once kids are in. That work will have to be done on off hours, it'll have to be done on weekends, but we're also we're doing long-term fixes to ensure that we don't have to have these short-term fixes in place intermittently. So we're here, we're responsive. Whatever the issues are, we're going to address them.
Okay, I'm going to call on people who have their hand up for the first time. Some have their hand up twice. So the next speaker is Dr. Janice Johnson-Diaz.
Hello. Thank you so much. I have a few comments and a few questions, but I want to begin by stating openly and clearly that I think opening up the high school is a fundamentally bad idea, and we should not do it. I also want to be clear that we must invest and protect our teachers, administration, and children. As for tonight, I found the presentation and the interpretation of the data tonight troublesome. A lot of conclusions were drawn, generalizabilities made with limited data or small sample sizes. Additionally, I heard the data regarding COVID spread in schools, and the evidence says that 1st through 8th grade are at low risk. But what of the high school? Further, what evidence do we have that a high school with a population of 2,400 kids in a poorly ventilated building will likely get infected? There's a lot of medical data going around, but I've not heard a public health response to these issues. The assumptions being made here tonight says that children are not embedded in families, schools exist in isolation. How might a public health approach, rather than a medical approach to this issue, be different? I finally want to draw attention to the Black and Brown folks and the casualness with which we talk about their lives. The comments made tonight echo those made by the previous president. It is what it is, but it isn't for those of us who live in these bodies. The choice of words used to describe the issues of mental health faced in our communities only exist because of structural racism. I object to the fact that the decisions about what should happen in our schools, which are largely Black and Brown, is being made by those who do not understand that our lives are not expendable. So if all lives matter, and indeed they do, we must rethink this decision to open the high school.
I'll let Dr. Joseph, I think Dr. Chasse, touch upon the data question. And I would defer to Dr. Campbell, to address the, as a woman of color on the committee, and a physician and a mother in town, to address Dr. Johnson's questions, commentaries on that. Please understand that if I was misperceived as being casual, and of course, no one in the audience is in my mind or walks in my shoes, but I can assure you that that none of the decisions that I make as superintendent, I make lightly. And the choices are not simple ones. In some ways, the impetus for us opening, and of course, we're not obliging any students to come. I mean, we've offered parents and students the opportunity, if they don't feel comfortable sending their kids in, to not send their kids in. And so there isn't an obligatory requirement to do that. But in fact, part of the impetus for us offering that opportunity is because we know that many of our families and students are struggling at home and need the support of being in schools. I was at Roosevelt School today, and obviously that's not the high school, but it's a larger school, and being a middle school, and I walked the building with Principal Hush, and there actually was there were a couple of autistic classes that were in this week. And I said, Lionel, how many students will you have in the building on a daily basis when you think of those who are coming in for hybrid, and then the fact that we've broken them up into 4 cohorts? And he said he'd have about 70 students in the building, in Roosevelt building on a daily basis. Now it's slightly more at the high school because it's a larger building, but we've been extremely conservative in the amount of time that students are going to be they're going to have on site, where many high schools are doing 50-50 cohorts. My children's high school is a 50-50 cohort. We're doing 25% cohorts, and specifically for that reason, to really reduce the number of students in the building on a given day and the number of students that are in a classroom, to be as cautious as possible, and really erring on the side of safety for our teachers. We've been, while in some school districts they've erred on the side of liberal when it comes to the social distancing between desks, and those are your 50% cohort schools typically don't have 6 feet between desks, and that's how they're able to get 50% of their students in the school. We've remained that fidelity to that 6 feet, and as such, it's enabled us to bring in 25% of the student population. And a final, point I would just make relative to the assertion the building is poorly ventilated. I would tell you that back in August, I would agree with that. What I say that we know that we have long-term remediations and costly remediations that need to be made to our ventilation systems, but the remediations that we put in place are ensuring that there's a working mechanical ventilation system in the classroom, meaning that it's a blower that's running, that's moving air, that There is a damper that is either functioning in an automated fashion, or we've analyzed and studied the damper opening that's necessary, and manually opening those dampers to ensure that we're getting the necessary fresh air exchange. And we've invested $600,000 into the installation of bipolar needlepoint ionization technology on all of our mechanical univents. And in those rooms that may not have that capacity, we've installed mobile units and had those units retrofitted with a needlepoint bipolar ionization device on them. So, while we have long-term remediations to do, whereas in August, I did not feel comfortable certifying our buildings specifically because of ventilation, and that's why we postponed initially in August. I feel much more comfortable and confident in that, in the status of those facilities. But I would turn it first over to Dr. Josephs and Dr. Chasse to speak to the questions about the data. But I also know that there's a public health piece there. So I feel as if the local Department of Health, and I don't know if you wanted to ask for clarification along those lines relative to the question, but it seems to me that would be an appropriate question for the local department. So let's start with Dr. Josephs on data. Go to Dr. Campbell relative to equity. And then maybe we'll conclude with the West Orange Department of Health. And if you wanted to ask a redirect to speak to it from a public health standpoint. Dr. Josephs?
Sure. I'm just going to share my screen here. Hopefully everybody can see this. So this is data from the WHO, World Health Organization. And what you see here are graphs of various countries measuring how likely people are to get infected with COVID in a number of different countries, as you can see, but I'll just focus on the overall. And what you see is the sort of middle line here that I'm tracing with the cursor, which is infections that develop symptoms, is actually relatively low from the ages of 0 and actually bottoms out at about 15 or 16, and then pretty much rises continuously from that age until the cutoff, which for them looks to be about 80 to 85. So that's the first piece. Hard to get COVID if you're younger. Not impossible. Note, I'm not saying it's not possible. I'm saying it's harder. Second piece is, I'll just stop sharing for a second. I'm aware, and I'm by no means have surveyed the entire literature, but I'm aware of 2 major outbreaks of large percentages of the students in a given place that have happened in high school age groups that really caused a place to actually have to shut down. And that's only 2 of hundreds of outbreaks. So there's lots of outbreaks, but many and only small numbers of cases. The 2 situations I'm aware of, one, a day camp in Georgia, where students came to the camp infected. It was the summertime, it's Georgia, so it's obviously very hot. Not all the facilities were air conditioned, and the buildings that were had airflow that infected other people. The other in Israel, same situation, except there's no air conditioning. So they let the students take off their masks. Percentage of people who got infected with COVID in those 2 outbreaks was about 10%. So yes, Dr. Johnson, there are some situations that you can create that do lead to large scale outbreaks. You're entirely correct about that. Obviously, that's got to be up to Dr. Cascone and the facilities people in the schools that something like that were to be identified. You got to make a change in the way schools being conducted. And it sounds like there are already plans, if I understood Dr. Cascone correctly, for how to ameliorate such situations. From a public health perspective, of course, the school district can't control what the students choose to do when they're not physically there. And that, from a public health perspective, is where, as Dr. Cascone was saying earlier, we really all need to be on the same page that COVID's not going anywhere anytime soon. And so continuing to maintain, knowledge about what your children are doing when they're not in the building is vitally important. I will let and defer to Dr. Cascone what he's doing about temperature checks and symptom screeners and all of those things prior to people coming into the building. I don't know what the district's plans are for that. But that again, of course, is why those types of measures are implemented. I don't know, Dr. Chisse, if you want to add anything to what I've said so far.
Not really. I mean, I am definitely on board with what you were saying. I'll say for the numbers, we're not looking, I know you had said it's a small sample size, which, you know, again, if the situation was we're looking to publish a paper on, you know, the percentage of something within, you know, a large sample, it would be more applicable, but we're looking at community burden. It's going to be small. We want to look at community burden because again, as I had mentioned before, we're looking at the factors of community burden and implementing the mitigation strategies. So, you know, it's new cases in the community in the past 14 days. We're looking at, you know, or percentage of the PCR tests that are positive within the last 14 days within the small, you want small sample because we're looking at in the community. The second thing, again, as I had mentioned before, the mitigation strategies, if that is implemented in the school and in the community. So, you know, again, like Dr. Josephs was saying, what we do outside of school is vital to what happens with the children in school. So not only in school having the consistent use of the masks, the correct use of the masks, the social distancing, hand hygiene, respiratory etiquette, which, you know, again, you know, we wash our hands, we cover our sneezes. Yes, we have masks on, but they're little kids. So we may take our mask off so we can sneeze. A lot of children will do that because they feel like they have to take their mask off to sneeze. Again, teaching them the respiratory etiquette, showing them, you know, how to wash their hands after, you know, singing or counting each finger twice. It's going to be your 20 seconds, the hand hygiene, the cleaning and disinfecting, and again, having the contact tracing and the collaboration with the local health department. All of these mitigation strategies are being implemented, as far as I know, in West Orange. So again, this with the community burden, you know, lowers the risk significantly, and implementing those mitigation strategies at home, staying within your cohort. You know, yes, you're probably going to take your masks off at home. Everybody was saying, you know, that who eats at home with their mask. Well, if you are infected, it's a completely different story. But if you're not and you're within your little group, that's fine. If you are going out to dinner, which, you know, at this point I wouldn't recommend, but again, if you're going to go out to dinner and it is inside, when you take your mask off, you should be with your pod. That's something that we need to continue to push. You know, if people are going to be socializing, they need to be, yes, socializing is good, talk to people, but, you know, people that are under your roof, people that are in your pod that you're seeing on a consistent basis. We're not trying to all of a sudden go out and, you know, party here and go out to dinner here and go to the bar there and then come home to your kids and then send your kids to school. So again, all of this from a public health perspective leads into preventing the transmission within the schools.
Dr. Campbell, thank you, Dr. Joseph. Dr. Campbell, you want to just follow up?
I mean, I just, you know, undoubtedly, one of the things, you know, that we have learned, I mean, I'm aware, I don't know, but maybe it seemed that some people may be finding out for the first time are the racial and ethnic disparities. And while we see them in healthcare, we know that they exist in many spheres of our society. And so, I mean, there's no doubt that there's a lot of work to be done. And when we look at the disparities in healthcare, I mean, they are a symptom of it's just a small microcosm of our entire society. And so we know that there are disparities also in our educational system. And, you know, I have 2 children, but I am very invested not only in my kids, but in everybody else's kids, because I need everybody else's kids to have a great education, to be great leaders and community members. My 2 kids won't be able to to just take care of me. We need everybody. So from a community perspective, I don't take my own privilege for granted. And it's really, really, really important for me that everybody's kids have the opportunity and safely. And so I think in this conversation, we definitely have to keep at the top of the mind ensuring equitable resources that support a safe learning environment and that it's equally distributed to all of our children. So I definitely believe in equity.
Yeah, and I would just follow up and say just what we've learned throughout this pandemic is that the closure of our schools, the inability of students to be in our schools has impacted disproportionately from an academic standpoint our economically disadvantaged students and many members of our minority community. Whether it's internet access or parental supported homes. So I mean, if anything, the one of the impetus for coming in is to serve those communities that are in greater need, and those kids that are greater in need, because they don't have necessarily have the support and the resources at home that they need. And that's not a criticism. It's just that's the reality in some cases. So that's actually part of our rationale, because it's not the regardless of race, it's not students of economic advantage that are struggling academically anyway. It's not to say that anyone's immune from the social, emotional, and mental struggles, but it's not typically our economically advantaged students that are struggling during the closures. Mr. Massey, how are we looking in terms of, I know we're at about 9:20, and I want to be respectful of our panelists' time.
Yes, we have 32 hands up. And how would you like to proceed?
Well, I would say maybe we'll go another 10 minutes. Again, we're going about 30 minutes beyond what I had asked our participants to do, and I want to be respectful of their time. I'm happy to stay on beyond that. I can't guarantee you that I'll be able to authoritatively answer questions that are scientific or public health based, but I'll do my best. I'm happy to stay on beyond that, but I will only oblige our participants to stay on an additional 10 minutes. And then if they have family commitments, personal commitments, you're more than welcome to take your leave of the group.
Okay, so the next speaker is Rachel Goodman.
So I think that a lot of great points have been brought up, but we really need to address those metrics, to use Dr. Cascone's terms, that actually demonstrate the danger of reopening, especially with the more easily spread UK variant now in the area that no one has brought up yet. Our NYC neighbors just buried their 100th staff member today who contracted COVID from in-person learning, and half of their elementary schools are closed on any given day because of outbreaks. Since schools reopened, the CDC has stated that cases of children infected in school went up from 1.7% to 7.3%, and over 12,000 kids have been hospitalized so far. I would also challenge what was said tonight regarding children and COVID, because over the weekend, the EU backed a study that children are almost equally, if not more often, infected by COVID than others. And at least 6 countries in the EU are moving to shut their schools because they have seen significant school transmission. And just because, as was stated tonight, young people are asymptomatic or they survive, that doesn't mean that they end up healthy. 30% of college athletes have long-term heart damage because of COVID, as just one example, and there's no way to know what the long-term effects are of them contracting the disease. Additionally, as of last week, it was released that 12% of patients who quote unquote survive COVID die within 5 months anyway. It seems nearly impossible to disentangle the influence of school closures from lower transmission and death rates, especially since we have teachers who live all over the state and not just in our community, which means that our community numbers are not the only ones that need to be considered. And the state numbers overall are still applicable because they're traveling from all over the state. And to echo others, I want to know why we can't wait until the Biden administration releases their full audit on schools announced earlier today and their promised guidelines for safe reopening, especially since Superintendent Cascone has lambasted the lack of federal guidance as one of the primary reasons for moving ahead with reopening anyway, especially when over 1,000 community members have spoken up against reopening. In case it's been left out here.
Thank you. That's 1 minute.
One more thing. What was echoed in the previous speaker, that there's been some disgusting ableism brought up tonight in your arguments, and just because someone has a disability or they are Black or Latino or Native, those students most likely to contract COVID, or you're elderly or too poor to retire from teaching. Your life is not worth less and shouldn't be seen as a necessary sacrifice for everyone else to return. Thank you.
I would just like to just calibrate with my fellow panelists here. Does anyone recall anyone on this panel making statements of either nature? Because I mean, I certainly didn't. Does anyone recall that happening? So I would just ask Ms. Goodman to be as the professional reputations of the people on this panel are at stake here, that perhaps you choose your words more carefully, because I certainly didn't make that statement. And if I might just continue to kind of get up on my soapbox for a moment, Ms. Goodman, I am a person who's labored within this profession of education for the last 2 decades. I've been an advocate for equity, I've been an advocate for kids, and I've been an advocate for teachers everywhere I've gone. I would never make a statement of either of those sorts. And that's demonstrated not only in my day-to-day conduct with my stakeholders, but also the manner in which I go about my business, not only in West Orange, but everywhere I've been previously. So I feel, imperative to state that. But I would turn this back over to Dr. Josephs. And for those who, and I don't know if everyone joined from the beginning, I'm an educator. I'm an educational leader. I'm not a doctor. I'm not a public health expert. And so I can either try to make sense of and play resident statistician or public health expert and try and make sense of the morass of different articles and medical narratives that are out there, or I can defer to people who are trained to do that. And that's what I'm doing. And so I'll ask Dr. Josephs to follow up relative to some of the assertions that were made initially relative to the data, and just see if you had any insights on that.
Yeah, I'm trying to review in real time, which is difficult, the last report of the European version of our CDC. I'll tell you the date. Let's see here. Scroll to the top. Let's see, when was this issued? 23rd December 2020. So that's the last official review I can find in real time of data by the European CDC, in which they echo many of the things that I've said this evening. I think from a public health perspective, when you think about reopening a school, you're weighing what's the risk of COVID to the students, COVID to the faculty, with what's the other risks to the students from everything else that's involved with the good benefits you get from schools, whether that's the students in the school system who receive benefits through Healthy Start and their school meals, to having access to the school nurse, to the educational benefits of school. The American Academy of Pediatrics, which is the leading group of pediatricians in the country, has said, in their opinion, that the benefits of all of those things outweigh the risk of damage due to COVID. What you've said is correct. There are long-haul COVID cases who do suffer long-term consequences from COVID. Whether that number is 30%, I don't know. I trust you've looked at the data. I have not looked at that number myself. I'd have to, spend some time in the literature. I think, like everything in life, it's a risk-benefit discussion. As I privately messaged Dr. Cascone at one point this evening, there's a chance you could be hit by a car driving to school. The bus could flip over. Those are known risks of attending a school. COVID has known risks. what's the balance? That's why we have these meetings. That's why Dr. Cascone does, I'm sure, everything he can to make sure that if the district goes back, it will be safe as possible to go back. There's no zero risk situation that I can conceive of with COVID or with anything else to make the district totally safe.
I just got a cue in the chat from Mrs. Tomasi from folks who have questions that they want to get to the panelists. Obviously, we've been taking questions for about an hour and a half, and unlike our board, we'll stay all night if we need to. I want to be respectful of our panelists' time. So I would say if there are questions, I'm very accessible, and you're more than welcome to email those questions to me, and I can ultimately get feedback from the panelists. And again, I'm happy to stay on and answer questions that are more administrative in nature or that are of a public health nature that I feel comfortable in. So I'm happy to do that if people want to stay on. But at this time, I would just say I'd just like to thank our panelists and any panelists that at this time. If there's Ms. Trigg-Scales.
Yes. Good evening again. I just want to commend Dr. Cascone on behalf of the board to have gathered this group tonight, and it was done in a short amount of time. This was not planned weeks ago. I think is quite commendable. I certainly learned quite a bit tonight. I think the one thing is that there was so much confusion, at least on my part, and I'm sure on the part of others in the community, how the positivity rate was calculated, what that had to do with the local level versus the county versus the regional. How did we decide as a district that we were going to open? The board's responsibility is not to run the district. We've said this before. It's to ensure that the district is well run. And we're very confident in Dr. Scott Cascone. We have watched him during his tenure here. His commitment to the students, to the staff, goes way above and beyond many superintendents. It's genuine, it's committed, and he's dedicated to what he's doing. And everything he does is quite measured. The decision to open has been measured. We've looked at the data. We will continue to look at the data. Once school is open, the board will be asking for data on a regular basis from Dr. Cascone. What's the student attendance rate? What's the staff's attendance rate? Are there outbreaks? What's the positivity rate on a daily basis? What's the quality of instruction? That's really important. Once we go to hybrid, what is the quality of instruction? We've never done this before. So we'll really want to know what's happening in those classrooms. Health and safety is primary. But what I want everybody to know that this decision to open is reversible. It's not as if once we open, that's it. If we find that we're not moving in the right direction, if Dr. Cascone believes that the quality of instruction is not where it should be, that the health and safety is not where it should be, then another decision will be made. So again, I want to thank everybody who was on this evening, especially our panelists. To have given your time tonight is so much appreciated. And again, on behalf of the board, we can't thank you enough for giving West Orange your time this evening. Thank you.
And I would, I'd like to echo that. And I think it's important, for the community to understand kind of where my head was at on this, right? So, that prior to the holidays, I sent the message that we were going to prepare to open. And when, you know, and I obviously I understood that there was some strong opposition to that, not only from some of our staff members, but also members of the community who were advocating on behalf of the staff. And so I needed to understand, I need to make sure I understood. And that's precisely why on last Friday, I called, you know, a meeting, and I met with the Department of Health, and I wanted to calibrate my understanding of what I was seeing and make sure that, you know, if we were to move forward with opening, this was not something foolhardy. This was not a layman's view of things, a layman's perspective on things, because obviously I know, you know, what the stakes are, and I bear that responsibility. But still, even after that meeting, I said to myself, this is great for me, because I walked away from the meeting feeling on some level, some measure of confidence. But I knew that if I didn't try and engender and build some sense of increased confidence within the community, that we couldn't embark on this. And in some ways, you know, this was a revelatory meeting for me as well. And I know there, you know, perhaps there's folks out there that thought, you know, on some level this was, you know, this was staged. I stacked the deck with people who were going to tell you what I wanted you to hear. But the reality of it was, I went into this opportunity in as much as a learning opportunity as well. And I was as much interested in calibrating my understanding and corroborating my understanding with the new perspectives that were brought to bear here. And I was fully prepared for whether it was Dr. Josephs or Dr. Campbell or anyone on this call to come to this meet and to provide a perspective that or Dr. Keller, that contradicted my current understanding and view. And if information was brought to bear by the medical and public health experts in this group that contradicted that, that's what I wanted to understand. And, you know, my impression of what I've heard tonight, regardless, and I have a tremendous amount of respect for the medical professionals that are on this call, is it's not contradicting that which, you know, we discussed on Friday, and it was not contradicting that which, and not considering the risks that I wasn't already kind of, from a layman's perspective, as a superintendent, sort of leaning towards. But I needed to know, I needed to have that corroborated or not. And I just want you to know that this was not a fait accompli. We didn't come into this a fait accompli, like this is done. This is just a charade. This is just an extra machination for show. And I'm saying that publicly and honestly. Ultimately, whether folks in the community wish to believe that, you know, that's your choice. But I'm saying it on the record and publicly that it was not a machination. It was not a charade. It was an opportunity for me, and as much as the community, to get a full objective picture from people who are qualified to give it. And with that, I would excuse the panelists. Again, I thank you. Again, if there's anybody who's interested in staying on, I'm happy to stay on. You know, if you want to lodge your questions, or you can submit them in writing to me, and I'm happy to either answer them myself personally or have one of our experts do that.
I'm absolutely fine staying as well, Dr. C. So you just let me know when you want to take the next person.
Let's do it. Let's take the next person. Good night, everyone.
I just wanted to say, Dr. Cascone, going forward, if parents do have medical questions, I certainly, you know, we have them submitted. Maybe we can do a FAQs or something of that nature. If people have questions that we can answer later on. I'll stay on for a little while, although I'm going to munch since I haven't had my dinner yet.
Yeah, Dr. Campbell, I'm open to that as well. If there's, you know, more from, you know, public health perspective or what have you, you know, FAQs we can get together and then maybe submit a document or something to help answer those.
Well, I would love, I think, I appreciate that very much. And I think being a resource to the staff to me is probably the more critical piece. And I could be wrong, but I think, most of the folks who are sending their kids to school are in support of us, going back, and folks who are, planning to keep their kids virtual, generally tend to be the ones who are opposed to it. So I think that to have you as a support structure for staff members, in the upcoming days, I think, whether it's FAQs or what have you, I think would be really, really helpful. So thank you. Ms. Tomasi, does anyone else before you leave wish to issue any parting thoughts? Dr. Schurz, any parting thoughts?
I'll stay with you because I know that families don't get much of an opportunity to be able to field questions. So I'll stay with you.
I'll stick around a little while longer. I do have some obligations tomorrow, so I can't stay all evening, but I'll try to stay on a bit longer. I just want to share the data from New York because it was brought up. New York is actually doing surveillance testing. So they send people to the schools and test sort of samples of school students and faculty for COVID. They've been doing that since the 9th of October through yesterday. So I'll just give you the numbers: 339,000 tests, 339,195 tests, 139,000 students, 196,000 staff. The citywide testing positivity rate in those 300-some thousand people, 0.49%. The citywide overall positivity rate during that same period is probably about 8%. So detecting way fewer infections in people who are in school than the overall positivity rate in the city. I could break that down by borough for those who are interested, but I won't for the sake of time. And I'll just give you yesterday's number: 3,885 tests, no infections detected. While in the city overall yesterday, 5,000 infections for a positivity rate of 4.3%. So doesn't look like there's much infection in schools. I know the buildings are getting closed, but the overall numbers quite low.
Thank you, Dr. Joseph.
Of course.
Ms. Tomasi.
Okay, if your tiles disappear, we'll all understand. The next person who's got their hand up is Aaron Kesselman.
Thank you. This has been very informative. Aaron Kesselman, 1 Galloway Court. So a couple questions. There's always a level of risk with students, faculty, staff going to school. They get flu, lice, TB, etc., chickenpox, right? I mean, so why is this new? Why is this a real issue? There is no ability to mandate this vaccine, right? Correct me if I'm wrong on that. Because teachers are asking to get a vaccine, or at least to come back with having it, but you can't mandate it, right? Okay. Also, if there's an issue with, I would imagine, I think Dr. C has actually brought this up before, but if there's an issue with the teacher's room, wouldn't they bring it up with the building super or principal? Just, something that I think I've heard before. And if a teacher has, correct me if I'm wrong on this, with the current vaccine, guidelines and what those can sign up, if there's a teacher that has, between the ages of 18 and 64, has a pre-existing condition that is now allowed to be able to get the vaccine, couldn't they sign up? Just a couple questions. Again, this has been very informative. Thank you.
Okay, should I continue or?
Yeah.
Okay. The next person is Miss Paul.
Hello, can you hear me?
Yes, we can.
Okay, just one question, and thank you, Dr. C. I'm a teacher in district. You know me well. Just a question because we're all concerned going back, And we've heard it a bunch of times tonight that it's a whole community issue and we need to make sure that the community is making the right choices. We've had our teachers called out on things on Facebook. People are doing different things. I've personally stayed in my house since March. I don't even go into a store. I'm afraid of absolutely everything except my children. But when I go in and I don't know where they are over the weekend, they went away over break, where they go over the weekends and different things that they're doing, different activities. Is there something you can do, maybe as the superintendent, a separate communication or something that you could do that's going to help us control the community behavior? Because we know it's community spread. You've said it's not, although I have those numbers in the New York, by the way, it's almost half the New York schools were closed yesterday. Almost half of the 850 that are allowed to open, it was almost 400. Thus, the numbers of tests from yesterday were low because half of the schools were closed. But my question is, how do we keep the community doing what they're supposed to do to keep our schools safe? I love these schools, you know that. I've been in them my entire life, but I don't want to give up my life for that. So what can you put out there to the public to tell them to please ensure it? Because we're going on blind faith here is what I feel like. Thank you.
Yeah, thank you, Ms. Paul. And, I don't know all the teachers in districts. I haven't had the opportunity to meet all of them personally, but I do know Ms. Paul and I can speak personally to her just amazing commitment to what she does. An exemplary teacher and truly committed to the district for sure. This doesn't directly answer the question. I will kind of circle back to to more directly answering it is we are, and I had received a question from a parent today regarding, what our travel protocol is going to be. And I know that that's different from, the kind of the casual weekend interaction, but we will be putting out guidelines to parents relative to, and staff for that matter, for travel protocol, traveling out of state, traveling out of country, and mandatory quarantines and things of that nature. Listen, I will stand from the roof. I will stand on the rooftops and, and the top of my soapbox and say it loud and say it often to our community. This pact, right? It has to be a pact. And how do you mandate that? We simply have to come together as a community on that. I think that the other piece is that if we don't, I think that the likelihood that we will be derailed by frequent closures will happen, right? So for all the folks who desperately want to have their kids in, and I get it, that's kind of to avoid an unpopular expression, that's kind of the quid pro quo one, isn't it? Which is, the ability for us to stay in school for prolonged periods of time and to keep people safe is predicated on the community's diligence insofar as their behaviors. Plain and simple. If we're not diligent, we're not going to stay in and we're going to be derailed. So we can all work towards that goal, but I have no problem messaging you. I know we don't have the entire community on the call tonight, obviously, but putting that in my messaging and regularly talking about it every chance I get. And that's the best I can do, but I'm happy to do that.
Okay, the next speaker is Chanel Rodriguez.
I hope everybody's having a great night tonight. I just want to say thank you for putting this together as in, with such, shorter time frame. So just want to share some things with you. So as you guys were speaking, I was just writing some points down. I just want to just, give my points out and hopefully you guys can clear this up. So whenever we're dealing with data, we're often given percentages and these percentages always seem kind of minute until that percentage actually transmutes to a person and materializes into several of your loved ones. I personally had 10 family members contract COVID-19. 3 of the 10 died. Data, if you want to look at data, it would definitely show that my family and I were fortunate enough that 7 of the 10 survived. But the reality is that my family lost 3 members in a span of 6 months, 2 sisters in 1 week and my beloved grandmother. COVID-19 caused both of my aunts' remains to sit for 30 days after their deaths. ever been to a Zoom funeral? I have twice. Now, if you want to talk about fracture a person's mental health, that right there would do it. I totally understand that the vaccines have a 95% efficacy rate, and that the 5%, who will get infected, the vaccine won't work. They may not die, even if infected. But the thing is, when widespread vaccination happens, I can kind of begrudgingly deal with 50,000 deaths like we begrudgingly deal with the flu each year, as opposed to 400,000 deaths within a 10-month span. COVID-19 is definitely decimating communities of color and those below socioeconomic status. We don't like to admit these inconvenient truths, but like it or not, our schools are stratified. Schools like Washington will experience very different rates of transmission because of the racial and socioeconomic makeup of the student population. And yes, I totally get that schools are not the place of transmission, but unfortunately, people who work there and the students who attend there can act irresponsibly and spread the disease there. I keep hearing the community has to do their part. We need everyone to do their part, and I totally hear that. But we're asking strangers to make decisions to keep other
Thank
strangers.
you, Ms. Rodriguez. That's 1 minute. Sorry.
Okay. If I could just say my only purpose for saying this is that I would like thank you for the opportunity to have students and families to make the best decision for themselves and to decide to go virtual. Why not allow teachers to decide if they feel comfortable going in as opposed to not? I'll just ask that they have the same choice that the families have. Thank you.
Okay, the next person up to speak is Jesse Aporta.
Hi, thank you everyone for sticking on as late to answer these questions. Both a resident and a teacher at the high school. And of course, we want it to be true that schools are uniformly safe and kids are not contributing to community spread. Of course, we want to free parents from the burdens of simultaneous work and childcare. And of course, we want to go back in time and change our collective behavior as a nation so that schools can operate at something approaching normal. But wishing does not make it so. According to the CDC, up to 54% of infected persons have no idea where they contracted these infections. Based on what I'm hearing tonight about respiratory viruses spreading and the science behind everything, and seems statistically unlikely that both American children who have tested positive since the beginning of the pandemic and the likely millions more that are presumably asymptomatic don't account for some level of current community spread. What is the current rate of transmission in schools, particularly in communities similar to West Orange? Comparing schools like Livingston, West Essex, Verona, or Milburn seem to give a false sense of security because we do not, statistically speaking, reflect that same demographic. So I'd like to know the exact transmission rate in New Jersey school districts similar to West Orange in size and demographics, racial and ethnic, with the preponderance of schools in similar size and demographics in our specific region in fully virtual environments. What are the projections of caseload increases in West Orange? And then, due to the logistical issues with testing, as Dr. Joseph discussed earlier, am I right in assuming that it is nearly impossible to know the extent to which children who may have been infected in school, or that they may be asymptomatic and therefore bringing COVID-19 home to their families? And to paraphrase Dr.
Mr. Aporta, sorry, I gave you a little extra time. That's a minute.
Thank you for your time, Dr. Cascone. I'll email the rest of the questions. I appreciate it.
It's a really good question. I mean, I'm the one. I know there were questions, but the one that jumped out at me was comparative data of similar school districts, right? Size, demographics, I don't have that data. I think it's relevant data, if I can be frank. Dr. Joseph, anything you can is there? Would we have access to data like that?
Not in the United States, unfortunately. We don't have a centralized record-keeping system that permits the relationship of where people attend school to where they got tested to where they live to track that. There is data along those lines that I'm just not up to date on, so I'll find it out for you, Mr. Aporta, from the Scandinavian countries where they have universal health care, and they are able to ascertain that. But to my knowledge, the United States is not capable of tracking data that way.
Understood.
Okay, for the sake of time, and I know Dr. Campbell just gave the signal that she has to drop off the call. The next speaker is Joy Burnett.
Hi, good evening. I first want to start off by saying I am a teacher and parent in town, and I want to thank Dr. Cascone for his leadership. I am very proud of the job that he has been doing, and I have a lot of confidence in his care and concern for the staff and the students. With that being said, as an elementary teacher, I just want to say I really don't take much confidence in taking the temperatures of children, because in the 19 years that I've been teaching elementary, we know that parents who want to get their children in school give them medications to mask temperatures and fevers. And we have, as elementary teachers, have seen entire classes and staff taken down over children that have had illnesses masked and sent to school anyhow. I have been teaching children virtually who have been in other states as we have been going through virtual. I've had kids in Atlanta, in New York, and so children are still traveling and being exposed. So it's a little difficult for me to say that I can depend upon the community to care for my family as I would care for my family. You know, as I said, I'm a teacher and parent in town, and to speak on the mental health side, the demands on my time as a parent and a teacher have been compounded during this pandemic, and my load has not been lightened as a teacher. This is more difficult than the 19 years that I have ever taught, all of the workload that I have. So my mental state has already been compromised. Much has been said of the mental state of children. Well, my children are not experiencing anxiety from not being in school, but they are experiencing anxiety from being concerned that their mother is going to go to school and end up ill and not be able to care for them, because I am the sole care and provider in my home. So as a parent, I have the option not to send my children to school, but as a teacher, I have to make a choice of whether I'm going to go to school or stay home and not provide for my family. So please take, I understand, just let me please finish the statement. So I would just like that to be taken into account, that we don't have those options. So our mental health is being compromised even more because we have no options. Thank you.
Okay. The next speaker is Joanne DeSimone.
Hi, thank you. Pretty quickly, would like for anyone who can to discuss the risk and safety strategies as it relates to indoor sports, which is fast approaching. What can we do as a district to keep our athletes COVID free? Because PPE and distancing are very different animals for indoor sports as compared to what we're planning to do for in classroom. And Dr. Cascone, I was just wondering, was the bubble a part of the ventilation remediation assessment? Thanks.
Dr. C, do you want me to move on? Or?
No, I'll address that. It's a good question. And I have to say, Mrs. DeSimone, I'll have to follow up on the bubble. I mean, I know that the bubble was recently redone, and so has basically a modernized ventilation system in there. So I would assume that that it is taking the necessary air in and out. But I'll need to look into that. Sports is tricky, and it's something it's something I do believe that we have to continue to look at, particularly as it relates to the positivity rate in the community, because the regional risk matrix relative to where your community is in risk has different recommendations relative to indoor sports. Now, outside of schools being completely closed because of a positivity rate at the highest level, like for example, we saw in Farallon, which precipitated Farallon's closure for 2 weeks. They were in the highest level. I can only assume that they had a positivity rate of higher than 20% in their community, which is why they obligatorily closed for 2 weeks. But if we see that, then I think, and our community gets into that high range, we're going to have to monitor our sports and determine whether it's safe for us to have sports operating contemporaneously with students being in school. In terms of the precautions, and granted, this is indoor versus outdoor, but there are a really strict set of protocols that are provided by the state to govern that. And if the manner in which our fall sports and the athletic department manage fall sports and the relatively few incidences or cases that we experience in fall sports between July and late October is any indication of how it'll be handled inside. And I think that's another one of those balances. I mean, we saw the value in whether it was sports or whether it was marching band, the value that those activities had socially and emotionally and mentally for kids, not to mention the fact that we had athletes that as a result of having that final season gained full scholarships to play in college. And so it's a balance, but I do think that we'll have to monitor it. And in consultation with the local Department of Health, if those case rates go up too high, we might have to temporarily shut it down in order to preserve the ongoing administration of classes and operation of classes. And we have some runway there because obviously the high school isn't scheduled to open until February 8th. So we do have some time to evaluate that.
I'm going to drop off, but I just wanted to make a couple of closing comments. It was really my pleasure to be able to serve our community and answer questions. And I look forward, I hope if folks do have more medical questions, like I said, I'll be happy to help out where I can. And just as the teacher spoke about being the sole breadwinner for her house, there are so many in our community for which that is true, and they don't have the option of not going to work. So I really do empathize and understand that's really difficult situation in the hospital, because obviously there are so many situations where we have to be in person to provide care, and none of us, we signed up to help people, but we signed up to be physicians for many reasons, but not thinking that we were going to be in a pandemic or die. And there have been many nurses, physicians, and many other hospital workers who have lost life due to COVID. So one of the things that the hospital and some of the professional organizations did is they did set up a warm line for workers, which has been really important because, as was expressed, the stress and anxiety of going to work and having exposures and not knowing, because there is so much that we don't know, we're still learning, might be helpful for teachers. So I would just make that suggestion. And I think it's hard because we're saying that, how do I know if the community is going to do right by me? That's very hard. But we'll have to send out reminders. We have to encourage each other, our neighbors. We may have to send out reminders on Friday and just have different strategies. So I just want to put that out there. And thank you for having me. I'm sorry I have to go, but I will be happy to answer more questions later on.
Thank you, Dr. Campbell. The next person who may speak is Patricia Rudy.
Hello, can you hear me?
Yes, we can.
Hi, I just have one quick question, also regarding mental state of teachers. I'm also one of those teachers. I'm not high risk, but I have 2 young children. My parents help out with taking care of my young children, especially when I have to return to work. So I can't afford to take a leave because I just can't afford to have 2 small children. So my mental state of returning is I will wear my face shield, I will wear 2 masks, and I will hope that those AirPods can get through all those layers. But I just have a question. We've been talking about community accountability, especially if we're considering hybrid, especially during this time of consistent cases of 20 to 30 cases per day, 29 cases reported today. So it's staying pretty stagnant. Can we please try to hold parents more accountable for their actions by reporting symptoms, reporting if they've been near COVID positive people, such as their family members are COVID positive, but they think it's okay to send their child to school, even though their father, mother, sister, brother, or grandparent in the household is ill with COVID. That is going to affect our mental state. Yes, they could lie, but I would like to believe that they're not going to. I think it's easier to lie when that question and survey is not sitting in front of you daily. If it's something you have to fill out daily, like many school districts are doing, whether it's an app or something through PowerSchool, that they have to fill this out, and it's staring them in the face every day. And there might be a little guilt then if they check no, but their child really has been near a COVID positive person. There might be some guilt factor there. So if teachers are putting their lives at the mercy of parents and the entire West Orange community, not just our lives, our family members' lives, can there please be some accountability? All parents have at least access to a student Chromebook where they could log in and fill out that form. Only 25% of the students will be in the building on a daily basis. So it's not the entire student body that would have to be checked over. So I don't think the size of reporting students could be excused. I don't think that the access to technology could be excused. Everybody has a Chromebook. Can we please put the accountability daily on these parents so teachers can have some kind of ease in their mental state?
Yes.
Please.
Thank you, Ms. Rudy. Yes.
Doc, if I may.
Yeah, go.
One of my PSAs before I was going to jump off was going to be the contact tracing piece. Please answer the call. If you don't want to answer the call because you think it's a robocall, return the message. All the county contractors are trained to leave messages if you don't answer. There has to be some sort of self-responsibility with the parents and the children when you're going out to eat, when you're going to a store. We get the cases daily back from the contact tracers, and the amount of people that are unwilling to cooperate, it's incredible. It's still, at this point in this pandemic, why people wouldn't want to cooperate is beyond me. I don't understand. So to the community, please, if you see something, say something. If you see a large party, if you see a large gathering, that's what we're here for. You know, just recently in the governor's updates, there was 2 businesses in town that received fines for executive order violations. We're on it. Trust me when I tell you, we're on it. But we need to know about it. If we don't know about it, there's nothing we can do about it. So again, I echo the sentiments of everybody else, Doc. Thank you for putting this together. It's great to have the independent voices on the panel. It's a good perspective to get. And we're all in this together, and we're gonna get through it all together.
Thank you, Nick.
Dr. C, just checking in with you. It's 10:06. What would you like to do?
How many hands we have up?
18 hands.
Let's keep going.
Okay. The next speaker is Tracy O'Hara.
Hi, thank you all. Thank you, Dr. Cascone, and to everyone on the panel tonight. I hear so many people, so many parents especially, comparing their office to, oh, first of all, let me say I'm a parent in the district. I am a product of the West Orange School District myself, a parent in the district, and I work in a neighboring district that is very similar in size and demographics to West Orange, and the district I work in is also in the same exact boat of making their final evaluation on returning to school. So I'm looking at this from a lot of different perspectives. I hear so many other parents, though, comparing their office jobs and having to return to work in person to being in a classroom and teachers having to return to a classroom. I'm curious how many of these people have actually been in a classroom in a capacity other than a parent, because with privacy issues and laws, I'm sure they haven't been in the classroom in a regular, work day. Even the doctors that are comparing it to their work environments, which are clearly more dangerous. And we are so appreciative of the amazing work that you're doing. But it needs to be noted that doctors are trained to safely handle this and teachers are not. So especially now, I work in a middle school, but especially for our elementary teachers and elementary students, what happens? There's a child that needs assistance, a child that's crying, having a meltdown, even something so little like a child that needs help with tying their shoes. These things, they can be done by 6 feet. What about children that have trouble following the rules of mask wearing, not touching others, staying seated, keeping 6 feet apart? Because anybody who's familiar with what happens in reality in an elementary classroom, they know that this is going to happen. I'm wondering if teachers, do they have a playbook on how to handle the hundreds of daily scenarios that occur any given day in a classroom to minimize the risk to themselves and students? Because I hear you saying that teachers need to, you or some of the medical professionals on the panel, that teachers need to teach children to reinforce them to keep their masks on, wash their hands, don't take off masks when you sneeze, etc. But these teachers also are tasked with teaching academic subjects, and they're being held to standards to,
Ms. O'Hara, I'm so sorry, that's a minute.
Okay, real quick, I just want to know what kind of training, because my district is not training. We're not getting training on any of this. So what is West Orange doing to train their teachers? Dr. Cascone, I know this is a hard decision. I wouldn't want to be in your shoes, but I implore you, listen to our teachers and don't drive your decision on parents' emotional pleas. That's all. Thanks so much. Good night.
I mean, we've, training, we've spent more time than, because we've postponed, we've spent more time than most, devising the plan, refining the plan. We've ramped up. Now, this is now our third ramp up. And so every time we've ramped up and prepared to open, we've gone through kind of another battery of training and refreshers on the health and safety protocol. I think in terms of the resources that we've invested, whether it's software or hardware, into equipping our teachers with everything they could possibly need to be able to deliver hybrid instruction. I know that's not a health and safety piece, but just on the training side. And I think we've done a good job, with availing the training to teachers, including investing funds into appointing a technology integration specialist in each of our elementary schools and multiple staff members in our middle schools and high schools. So I think we've done a good job with the training. And I don't want to speak too much because I know we have some other people that want to ask questions, but this is not this decision is not based exclusively on the wants and the asks of a large portion of our parent population. In the end, what's heart-wrenching as a superintendent, the kind of conflicted decision that the longer I operate within it and manage it, the longer I think it's not a situation you ever really will get over. It's not something that it'll ease in time, but it'll never go away. That's what and listen, it comes with the territory, I guess. With the roll heavy's the crown, I suppose. But to make a decision where I know that kids, and listen, our teachers, I gotta tell you, I would put our virtual model up against any district. What our teachers have done virtually is just absolutely outstanding. But we have kids who are really, really struggling. They're struggling mentally, they're struggling academically. And so to be in a situation as a superintendent where, on one hand, I know I'm failing kids. I know it. we talk about the risk, and I'm not minimizing it, but there's a very real risk that the longer we stay shut, the likelihood that that there's a tragic consequence there as well. So it's impossible. And I appreciate you saying you wouldn't want to be in my shoes. I don't want to be in my shoes most days. If I can be going back to Dr. Scherz and talk about vulnerability, and being transparent and vulnerable with you. There is no right answer, but I understand. I understand both sides equally well. Ms. Tomasi?
The next speaker is Jody Costanza.
Hello. I appreciate all of your input this evening, and Dr. Cascone, I respect you and Ms. Trigg-Scales and the board for gathering these professionals and having this meeting and allowing all the community members to have input. I, like Ms. Paul, have not left my house since March. I haven't hugged or seen my own mother since March. And my own mental health has suffered in many ways. And to say it simply, I am scared. And I know, the fear is real in a lot of us. At the high school level, although majority of the students have opted out and, we will see very limited number of kids, there will still be many adults in the building. Also, we have teachers and students within a cohort interacting throughout the day, moving from class to class, having mixing of levels of students in things like study hall. How safe is this, knowing the transmission rate amongst this particular age group is high? I also teach in the turnoff building at the high school, and I know I discussed this at the last board meeting, but if the room thermostat does not demand heat, then there is no fresh air coming in through the system, and not just for my room, but for all the rooms in the turnoff building. We also know that the needlepoint bipolar ionization that is supplementing the filtration can only work if there's a constant airflow pushing ions into our rooms. So if there is no call for heat coming from the thermostats in that building, that not only will I not get a fresh air exchange in my room, but there will also be no air moving through a filter and no ions entering my room to kill the virus. So would it be safe then to be in those rooms? And I know this is, a minute, and I just have one more question really directed to Dr. Scherz. And maybe Dr. Josephs, I'm not sure. Could you give us any insight into what the psychological effect may be on the students, especially the younger population, which, I don't teach, but on the opening and closing of schools due to COVID cases? My own niece's school was just opened last Monday and they're closed again. And, she's so excited to go back, and now she's, out again. And, just to see her face, she is very upset about it. And that's all. But thank you guys so much for everything.
Thank you, Ms. Costanza. I appreciate the questions. Relative to the and yes, right. So the high school and the middle school, you have students that are moving between classes, and what I would say is it kind of goes back to those mitigation strategies. A extremely conservative number of students in the building on a given day. One-way hallways, hundreds of thousands of dollars invested in alcohol-based wipes to be wiping down desks. And I think, the idea of, important is as important as what's happening in the classroom, something to be reinforced, and we've asked principals to reinforce this, is the interaction between adults in the building. We really have to be mindful of that, right? And so, where we're not congregating, adults together in spaces. I made note of the turn-off section because I know that's been brought up before, and my ask of the Buildings and Grounds Department was to work with Automated Logic to ensure that we program that system to maintain a consistently constantly running and a constantly open damper, and that can be done via the central control. I've asked for that to happen. I will follow up with them tomorrow and confirm that electronic control, that setting has been such that that damper is constantly open, so you're always getting fresh air and the blower is always running. But I will confirm that with our Buildings and Ground staff tomorrow.
Okay. The next speaker is Nicole Suriano Pastiglione.
Hi, good evening. How are you? I had a question. My question is if you think the eligibility of somebody being exposed and tested coming back into the building, the timeline, if that is enough time. And the reason why I asked that is because my husband was exposed by his doctor. We have been quarantined, isolating from each other, double masks, gloves. I got tested on day 2. Knew it was too early, but I am a type 1 diabetic. I am high risk. I was negative. I got tested on day 5. I was negative. Dr. Kelly said that I had the eligibility of going into work upon my husband's negative test result, that I was expected to go into work because I was cleared. I listened to my gut. I took a personal day. The next day we were supposed to be in at work. And thank God I listened to my gut. I went for a COVID test day 7. I am positive with COVID. So now, with me losing my father the day he was coming home, I had to call my mother and tell my mother that now her child has COVID. So now this goes public health and this goes mental health. Having to deal with that and tell my mother, who lost her husband of 51 years, that her type 1 diabetic daughter has tested positive, yet I was cleared to go back to work. I would have infected 4 adults and my children at the preschool level, which we are the first ones in. We have been. And for that, I want to know if the eligibility of going back in is going to be revisited, because obviously Dr. Kelly's advice was completely incorrect. And if I didn't go for a day 7 test, I would have infected my building and others.
Ms. Suriano, thank you, by the way, and appreciate your comments. And so just to confirm, your husband was positive.
Oh, I'm sorry. I just lowered her hand
Oh.
and removed her.
All right,
Yeah.
so right, so you know, Dr. Josephs, I don't know if you want to speak to, from your perspective, you know, what you would consider to be, you know, best practice or standard operating procedure as far as that goes.
Yeah, sure. So the question you just asked, Dr. Cascone, is part of the critical ones, meaning the doctor was positive, was her husband positive. That plays into it. But again, just going to share screen because I'm here for the data. That's why you brought me on the call. This is where this stuff comes from, is the CDC guidance on testing and quarantining. So even with testing, so these dark blue bars, Dr. Kelly told you that a negative test on day 5 plus no symptoms made you eligible to come back to work. I don't know if he knows these data or not. I assume he has some familiarity with them. That still gave about a 10% chance you could have COVID. So when does the risk go to truly 0? Well, it's about day 12 or day 14. So from a public health perspective, the reason that CDC went with the 10 days is because that's when the risk gets down to about, 1 or 2%. And that's what's blown up in this bigger graph up here in the right-hand corner. So I'm not sure what policy Dr. Kelly was using. I don't, do the medical clearances for your district, so I don't know. But this is the data as the CDC sees it as of last month, I believe it is, when they made the change from 14 days to 10 days. Now, if your husband has been negative the whole time, that raises an interesting question of testing at all. And there's testing because you want to have a test, which I totally agree with. Then there's testing because of the guidelines, and those are 2 different questions. But this is the data. So a day 5 test plus no symptoms gives you a probability still of about 10–15%.
I don't know if Mrs. Suriano is still on the call. I will I'm very interested in taking a closer look at that. You know, you provided a lot of details, and I want to make sure I have the timelines and the facts set straight, and understand what was the driver behind that decision from a public health standpoint. And I am very interested in that, because if we need to clarify, you know, what our entry protocol are, you know, we need to do it yesterday. And that's something I'm going to want to look at tomorrow. So, Nicole, I really appreciate you bringing that to my attention. And most importantly, sorry, and I'm going to turn to Dr. Scherz. My gosh, get well, and we wish you all the best for recovery. My gosh, I'm sorry. Sometimes, Nicole, you know, you're going on hour 15, and look at, you know, you're 10 months in the grinder of surviving, and Dr. Scherz will tell you, you know, you're in that survival mode. And I find I'm kind of a moment of vulnerability again with you. You know, you're in that survival mode, and I find myself, you know, having to remember to be sensitive, right? And you know, and even that, right? Like, I should have led with that, Nicole. But the first thing I should have said to you was, I wish you well and all the best for recovery. But you're in this survival mode, grinding for, and it just it brings an emotional detachment. And I find it happening, Dr. Scherz, and we talked about this. So I apologize, Nicole, and I'll definitely look into it.
Yeah, that's such a good point. You know, as the leader, you're so focused on logistics that it's easy to get into our heads and to sort of lose sight, you know, of the individual. But the last person who asked a question, you know, showed such thoughtfulness, you know, about our colleagues. She listened to her instinct, and you know, because of that, protected other people. She's caring about her mom, who's worried about her. Nothing is about herself, and that's really just so thoughtful. And to the caller before that asked about schools and students, you know, students are pretty resilient and adaptive. Two ways to sort of enhance that are preparing kids, you know, letting them know that there may be interruptions, and you know, helping them know that in advance, and they take their cues from the adults as well. So the better we do at dealing with potential stops and starts, the better they'll do as well.
Before we take the next question, Dr. Cascone, I do have to hop off to tend to some things before my work day tomorrow. I just want to thank everybody for their very thoughtful questions and comments. I've done this with a number of different schools now in districts all across northern New Jersey, and I commend y'all for being probably one of, if not the most thoughtful audiences that I've been able to join and help out with. And hopefully the data I've presented is clarified things for people. As others have said, I'll stay in touch with Dr. Cascone so he can forward whatever other medical or public health related questions, you know, to me to try to answer as I'm able, along with you know, the other folks who are helping the district. The last thing I just want to touch on is that you know, many people have referenced being troubled by the requirement for individual responsibility to control the pandemic, and that's one of the beauties and fatalities of being an American, and it's a cause of much of the disparities that we see in health in the United States. Is we don't have a national health care system that says, you know, the government cares for everybody. And we rely on that to do a lot of things in this country. That's just how the system is set up. I don't always wish it were that way. But with consistent messaging, it is very possible to get people to agree to and comply with important public health measures. So seatbelts first got into cars in 1968, I believe. And nationally, the use of seatbelt rates is 95+%, partly through some coercive tactics, you know, on the part of police, you know, stopping people for not wearing them, and a lot on the fact that we just have convinced people it's the right thing to do to safeguard their health and the health of their loved ones. And we're just going to have to take a similar approach to to COVID, that this is important to do, not just for you, but your loved ones, the community, your school, your faith community, whomever it is, the people you share your home with. And that's going to take time and energy, but I think we can do that. And, look, I'm going to be brutally honest. The truth is we were unprepared as public health professionals for this pandemic. You prepare for the pandemic that was before. That was Ebola. Ebola spreads and transmits in ways that are very distinct from COVID. We prepared for Ebola, we got COVID, and now we're in the mess of having to dig out from that blizzard, to use a winter metaphor. And we're trying to do our best by everybody as public health professionals and as physicians to give you all the most up-to-date advice that we have. I'll readily admit I've been wrong in things I've said to groups like this before. From the time I started doing this in March till today, I'll be wrong about some things I said on this call. What I've tried to do is be humble and present the data as best as I have it, and to tell you when I don't have any data to speak from. I have a list of a few things written down on my pad here by my side to check on for people that they've asked about, where I need to look more closely, that I can't do in real time. And I'm going to try to get back to Dr. Cascone this weekend if I can, with some answers to those things. And again, I appreciate everybody's vulnerability and willingness to speak openly about how COVID has affected them. I think it's affected everybody, on this call in some way, some, more profoundly or severely than others, but I appreciate everybody's willingness to talk about it. And again, I look forward to talking to Dr. Cascone and working through him to try to help the district in whatever way I can. Thank you very much, everybody, for your patience with me and the panel tonight, and have a great evening, and please stay safe.
Thank you, Dr. Joseph. Greatly appreciated, sir.
Thank you.
Okay, Dr. C, 14 hands up. Would you, time check is 10:30. What are your thoughts?
Well, I want to honor their presence and their questions. I owe them at least that, and I'll do my best to answer any questions I can. We have, of course, Dr. Schurz here from a mental health perspective, and if there are specific public health or medical questions, I'll make note of them, and if I can't answer them, I'll sure that somebody can. So let's keep going.
Okay, the next speaker is Danielle Sicola. Danielle Sicola.
Hello?
Yes, there you are.
Okay, thank you. Thank you so much. I want to start off by saying thank you so much for keeping us safe this far. It really is crucial to not just our physical health, but our mental health as well. We know what to expect every day going into work. I'm a teacher in district. We do know what to expect every day. Our students have really adapted. And I know it doesn't seem like it's well, but it's much better than that back and forth. That being said, I just have a few questions. To go back to the community accountability.
Danielle, it's very hard to hear you. Can you try coming closer to your microphone?
Sure. Is that better?
Yes, it is.
Okay, I'm sorry. I just have a few questions just to go back to community accountability. We don't know if students are exposed. We don't know if they're going to family gatherings or going away for the weekend. Just listening to my students talk in our morning meeting, I hear about all these places they are going to. Are they going to quarantine then? That doesn't leave me feeling safe. And then hearing Mr. Allegrino just say he's urging our community to be honest and communicate. He can't get people to return a message. How does that leave teachers feeling safe? We all know the masking with Tylenol to keep mask a fever. As a parent, I will be honest, I've done it. I have children. But the difference is now is we're only in school for 4 hours. How is that going to even be detected? The Tylenol wouldn't have worn off by then. It's a trust issue, and I hate to say that I don't have it, but listening to Mr. Allegrino just say, it really disheartened me that people aren't being honest. I live with my elderly grandparents and my immune comparable son. I cannot bring something home to him. I'm a single mom. I'm all they have. the 4 of them. This is not easy, Dr. Cascone. And again, as many have said, I would not want to be you. There are so many different sides to this category. But I just have one more question. Besides, how are we keeping our community accountable? Neighboring districts just as densely populated as West Orange are staying remote. Why? What makes us different? We're not immune. It really challenges to know that there's so many districts around us closing or staying remote. I feel like it just makes more sense. We cannot control what goes on outside of our schoolyard or in our schools, but we can control what comes in. So Dr. Cascone, I just need to understand why that's happening. And I know that it's not easy for you, but please reconsider and just think about it. Best practice is not back and forth to school. If we have to close often, as you said we would, if parents are not accountable, that is not best practice for our students. That's not giving them structure or continuity. That's not good mental health for them, especially the little ones. When my 2nd grader cries, or my 2nd grader has a bloody nose and I can't go near them and I have to wait for the nurse, what are my 14 students on Zoom doing? What are they doing at that point? Because they're not getting an education. I'm not teaching curriculum. I'm trying to attend to a child 3 feet away or 6 feet away. So please, Dr. Cascone, take those also into consideration, as I'm sure you have. Thank you.
Okay, let's see. The next speaker is Katie Schaub.
Hello, thank you so much for staying on so late to answer our questions. I have to be honest, I had something prepared and I now have about 6 pages of notes and questions. So I'll probably forward most of them in an email later on. Since most of the health experts have left already, I think I'm going to focus on some school-specific questions. My husband is a teacher. He's a teacher in Morris County. And his district has been open and has had, it does do daily screenings through a questionnaire where it is known that parents and students lie. People do not fill out the questionnaire and are not followed up with by the school nurse or principal until 11:30 a.m. and the school day ends at noon. Students are attending parties and family gatherings and still going to school. There have been cases where an entire family is COVID positive except one student, and the student is still sent to school. And the only way the administration is catching it in a timely manner is parents knowing that family in the community and reporting back on it. In fact, his administration has asked teachers to play detective, to report back on rumors, to basically tell on their students and tell on community members who are actively lying just to get accurate data from the community. So, I mean, I'd like to think that wouldn't happen in West Orange, but it's not impossible. And this destroys the trust between teachers and students, which is a sacred bond. And that cannot be good for anyone's mental health. So I'm sorry, I know I'm a little over a minute, but I just want to say he was recently exposed. He found out 4 days after his exposure. He only came into contact with 3 people. By that time, he would have already exposed me, who is high risk, and my mother, who is high risk. Luckily, he has tested negative, but it doesn't really put a lot of confidence in me when students go back in and there are hundreds of kids in the building at a time, when just coming into contact with 3 people, he was still exposed. Thank you so much for your time.
Okay. The next speaker is Alexandra Mizrahi. Mizrahi, sorry. Alexandra Mizrahi.
It's fine. Thank you. Thank you, you guys, for staying until this late. I just wanted to get to 2 questions. Can you explain why we're not doing a new survey for parents and teachers to be current and real data, as the previous surveys that was done with the premise that the moving from hybrid to virtual was immediately, but from virtual to hybrid had to wait until the next marking period. That's one. The other thing is, Dr. Campbell mentioned, in several occasions at the end as well, about that people have the option to opt out. So which is true. But you know what? Like I work for New Jersey Children's System of Care, and I'm being allowed to be home since February 28 due to my heart condition, and now my son recently conditioned. We are not going back to school. That's my choice. I was able to choose that for my kids, and I was lucky enough that the state allows me to work from home remotely because I'm the only paycheck that comes to this house. So my question is, and I said that in the previous meeting, why we as a parent have the choice and the options, and we cannot provide exactly the same to the teachers, staff, and everybody in the schools. I understand they are not doctors. They need to go to the hospital. They're not that. So why we don't try to coordinate a safe way where they can return? I mean, at the end, I'm allowed to stay home, but they are my family. I want them home. Thank you.
Yeah, we really have tried, it's tough as, as a person who has always felt as a person that has heart, it's got a big heart, that leads with heart, to the criticisms, how could you possibly, they bite hard. And so the question is, we've tried to, to be as accommodating as we can, while at the same time be able to operate the school district. For example, on the days when teachers come in, teachers were like, do we need to stay in the building for the entire day? We said, no, that doesn't make sense. Like when your kids are gone, you go take your lunch and then you can sign back on from home. You want to limit the time you're in the building. And a lot of districts are making teachers pay a portion of the sub rate or pay for the entire sub. I mean, these are some things that other school districts are doing, or asking their teachers to do. Other districts are saying, like, if you're quarantined, you're out and you have to take your days. Whereas before, under the federal legislation, teachers were granted 10 days, then they did not need to take their sick days. That sunset at the end of December. And so, we've said, no, we're not gonna make you take sick days to be quarantined. Like if you're home and you're quarantined, but you're healthy, work from home, teach from home virtually, and put a sub in the room. Going back to that idea of manageability in the school district is, if we're paying a teacher to be home, and then we're paying somebody to be in the room, we need somebody in that room, and then we layer that on top of some of the financial challenges that we face as a district, and we've invested millions of dollars into preparing our buildings to be able to open for hybrid. Like that financial piece is very real. And being able to find adequate people to be in the classroom. So it's tough. We've also in some cases where it's made sense and where the staff member's been able to perform their job at home. And we have some cases where, for example, we recently had a basic skills teacher where they were able to do everything they do virtually because of being able to platoon in the school, and colleagues in the school who were prepared to come in were willing to kind of platoon it and cede only virtual responsibilities to that teacher. And so where we've been able to, we've tried to make those accommodations. But at the end of the day, it's impossible for us to accommodate everyone, because at the end of the day, if one of our offerings is that on-site instruction where a teacher is going to instruct kids in class, ultimately. But, I will tell you that, this conversation has, not only as it relates to vaccines, but also as it relates to accommodations, has kind of led me to want to circle back with our human resources department, and understand, is there something else we can do? I don't know, I don't know, but I want to ask more questions about, is there more we can do to provide accommodations to people who are not able to come in? So I do want to have those conversations and understand if there's more we can do while at the same time being able to operate the school district. So I appreciate that, Alex.
Okay. The next speaker is Erica Leach.
Hi. Number one, I think I want to talk about seasons. I mean, I think it's kind of unlikely that teachers are going to get a vaccine before the new school year. So I do think if teachers have to go back without a vaccine, it would be more wise to open up the school when there's a lower transmission in the spring. And lastly, I know you just touched on this, but I think choice when it comes to teachers is very important. I think parents are given the choice whether they want to send their kids, and that same level of respect should be shown to the teachers. And that's it. Thank you.
Thank you. The next speaker is Deb Reese.
Hi, everybody. Thanks for staying on so late, and thanks for taking our calls. As I think you know, my name is Deb Reese, and I'm the general music teacher at Kelly Elementary. I'm also the vice president of the West Orange Educators Association. I just want to speak briefly to one of the points that a doctor made earlier, and that's while the use of PPE and hand washing, et cetera, may reduce the risk of exposure by tenfold, the number does not take into account human fallibility. We haven't talked about that. As any teacher can tell you, working with our students requires us to be in close contact. And for teachers of special needs students, the contact type and time required is even greater, which makes the probability of human error even higher. While we've worked hard to address the HVAC issues in our buildings, and I thank you for that, we haven't addressed the human elements that impact transmission and our respective safety. As we anticipate a return to school, I have two more questions for you, just what you wanted. How do we ensure that the available PPE will be used appropriately and accordingly for both staff and students, especially in some of our special education classrooms where students may have sensory issues which make mask wearing difficult, if not impossible? And also, a bit unrelated but equally important, if a room has been certified to hold 8 people, yet 12 kids plus a teacher and an aide are assigned to be in that room during a given cohort, how will that be dealt with? Again, thank you so much and have a good night.
Thank you, Ms. Reese. Another staff member with whom I've had the pleasure of becoming, better acquainted with, and another exemplary professional and really outstanding teacher. I miss seeing the concerts over there at Kelly School. Ms. Reese is the maestro over there. So I look forward to those days when we can get back to those assemblies. As far as the PPE as it relates to the special needs students, and this has been kind of an ongoing conversation we've had. And obviously it's a delicate one, right? Because it's a disability that's making it difficult for the student to do that. However, ultimately that student's disability doesn't trump the well-being, the health and safety of the staff members in the classroom. And so the way I've explained it is that there needs to be a process, relatively succinct process, whereby there's providing support to the parent at home to work with the child on mask wearing, to work with the child in school, and I'm not talking about prolonged periods of time, but to really try and make an impact behaviorally in a relatively short period of time. But, I've said, and we've spoken with our board council about this, that if even in spite of our best efforts, and not over a protracted period of time, but over a reasonable amount of time, where we can demonstrate that there was a process to try and work with the child, and we're not able to do that, then we can't allow the child in the classroom because it is a public health and safety risk. But there needs to be that give and take over a short period of time, because we don't want to expose our teachers to that risk for a prolonged period of time. So it can't be a process of months. It has to be a shorter process in which we're trying to get this and make progress. But I know that there's been a lot of dialogue, a lot of conversation around that with Mrs. Gogarty, Ms. Ribeiro, Mrs. Solombano over at the preschool. And I feel like the staff members know that they have the support of the superintendent and the administration, that we're not going to enable this to go on for long periods of time if we can't work with the student to have them be able to do that. Room occupancy, my understanding is that is that in the examination of those rooms, that Mrs. Gogarty, in looking at those rooms, has taken into consideration the multiple occupants, and and that most of our self-contained rooms, by virtue of the cohort system, have an extremely small number of students in them. I visited an autistic classroom in Roosevelt today, and that classroom will literally have one student when in the cohort. All the rest of those autistic students are virtual. There's one that's coming in, and I think that's more the norm, the rule rather than the exception with our self-contained classes. Very small numbers in those classrooms, and therefore, with the additional support persons in the classroom, those rooms. But again, if a staff member has concerns that that's not the case, open door. We want to know about it, and we'll have to address that.
Okay. Next speaker is Sharon Ortiz.
Good evening, and thank you for staying on so late. I'm happy to hear that you'll be revisiting the issue of why the dedicated professionals with medically documented high risk, like myself and my other colleagues, were denied accommodations and told that standard protocols of wearing a mask, washing their hands, and social distancing would be appropriate. When there is an abundance of new and recent indicators that say that clearly indicates that school spread from COVID is indeed a fact. Cedar Grove has been open for 7 days, and basically 3 or 4 half days. Cases spiked and the high school is now closed again. So that's a fact. In New York City, even with the middle and high schools closed, about half the elementary schools, as someone else mentioned, are closed on any given day due to COVID outbreaks. Another fact, on January 16, the number of students and staff testing positive for COVID-19 has surged past 10,000 teachers and students. Fact. And they have buried almost 100 members of their staff that have been infected and dealt with the kids, also a fact. So I do ask, please, that you renew and look at some of the newer numbers and the newer studies that have just been released within the last weeks or so, because the tide has turned and they definitely indicate that children are very much responsible for community spread. So I thank you again for having this. And I do ask that you just please keep that as a consideration. Thank you.
Just to touch on the data piece. I mean, I think that Dr. Josephs presented some really compelling data relative to the testing that's happening. That certainly, does not, acknowledge the passing of teachers in New York. That's that is what's the word I'm looking for? Strong, it's a strong statistic there, impactful for sure. But in terms of, I think, as much as we've, the purpose of this evening and bringing people who are qualified to speak to it from a data standpoint, not, looking at what's been published in this article or that article, but bringing real data from the healthcare profession. And then also when we look at locally is that, we keep hearing it's getting worse, but the data is not telling us it's getting worse. And, I want to just be clear on that, because if the data was telling me it was getting worse, then it would not be a hard decision at all. But that's not what it's telling us. It's not what they're telling me and what the data is telling me. And I would just go back to the data that Dr. Josephs provided relative to New York City and the surveillance testing and the lack, again, in terms of the idea that there were 0 cases and 30,000 tests because the schools were closed. Well, no, they tested in the schools that were open, and in those 30,000 tests, there were 0 cases. So I think that's there's always data that we can look at from both directions. Relative to the leave piece, again, I mean, I think the challenge is that if what we're promising is that we're offering, as we've been trying to get online and doing, is offering students some on-site instruction, that can't really be done effectively from home. That means that you're home and we have a substitute in the classroom. So the 2 days that the student comes in for on-site instruction, they're not having the benefit of their instructor on site. So I'm not suggesting it can't be done, but to ignore the fact that that's not in the spirit of what we're offering to people. I mean, I think it's not, right? So whether it's something that we're willing to accommodate as a district, like I said, I do want to revisit that with HR and with the board. And I guess I would just say again, and I know being in the classroom with students is a thing all of its own. But I think it's important for all the people who've been here, all the people who've been here, including me, and I know that some folks bristle at the fact, well, it's different being in an office. But I interact with people every day. I'm in a facility every day that has, anywhere between 20 and 30 people in it on a given day. I share a bathroom with people. There's visitors in this building. There's delivery people. There's all sorts of things happening in this building. And I've been in this building every day. The father of 3 children every day since March. And this district doesn't run what's happening at home doesn't happen if not for the countless employees who are here every day. And so, I would just say a word to them, to any of them that are listening, is that, people are working, and our lives are no less valuable than anybody else's. And we're here because we have to be. I don't have the luxury of being the superintendent for home, and I recognize that. And, ultimately, if I were to say to the board, well, listen, I can't come up. Would I be able to continue to serve as the superintendent of schools of this district if I wasn't able to actually come up? I don't know. But, I would just offer that up, that this district has continued to operate and move forward, yes, due to the efforts of the teachers at home teaching, but also due to the efforts of many, many staff members who come in on a daily basis to do their jobs. And I think it's important to honor their commitment and what they've been doing on a daily basis. Mrs. Demasi.
Okay, the next speaker is Michaela Bennett.
Hey, good evening. So, President Trigg-Scales, you look so tired and still you stay the course. I'm impressed by all 3 of you still here, and I thank you for that. If I could just, before my time starts, if I could just ask you to jot down a couple of points for clarification. And I'll be as brief as I can with the rest. But the first point I think that's super important is neither the CDC nor the state nor the county divides the percent positivity rate by 7, but our township does. And when you take away that step, what you've got is 56% instead of that 8, 72% instead of that 10.3. And then 50% based on what OEM Director Allegrino, I think is his name, what he had reported tonight. All of those are over 20%, which is what you discussed last week as being that benchmark for staying closed. I think it's extremely important that you know how the CDC, the state, and the county determines percent positivity, and that the township is consistent with that, so that you can make your determination at least the way the Department of Education expects you to in that regard. But that's, I think what they're doing is they're confusing the trailing, how you come up with the trailing percent positivity. And even that, I think that they're doing incorrectly. But
Ms. McGill, can you elaborate on that?
on which?
The trailing?
Yeah, well, good luck. You know, so I rely heavily upon, the Johns Hopkins engineer trained husband of mine to explain this stuff to me. So I'm not sure that I can elaborate for you on how a trailing rate is considered, but one of your math teachers explained to me today that you use a 14-day or a 7-day trailing to basically rule out inconsistencies or anomalies in rate, right? So you look at the trend. Am I saying this correctly? Yeah, he's shaking his head. You look at the reason that this is useful is you can see a trend, number one, and you can smooth out any anomalies. But the point that I think is important for you when you make determinations, particularly because determinations can come back to haunt you if they're made incorrectly, right? Like, the lawyer in me always thinks about the worst case scenario. I know I'm going over. I have something prepared that I promise you I've timed myself multiple times and it's under a minute. But this point that I just wanted to raise for clarification purposes, I think is critically important for you, because if you're way over 20%, right, more than double, sometimes triple or close to triple or more than triple, then you're not adhering to the guidance that your Department of Ed affords you. And I think that that's pretty important in the event of liability. But that was a point of clarification that I would have wanted to ask one of the doctors. I will tell you that I wrote down Maslow's hierarchy of human needs, because I think, and I'm only raising that right now because you've got the clinician in the room, right? Like, so before law school, I have, a clinical degree. And one of the things that I always worry about is you gotta tend to safety and security before you can tend to the other higher level emotional needs. And anyway, here's what I would have said very quickly. In light of the time constraint tonight, I wanted to limit my remarks and not discuss any metrics or benchmarks, platforms or guidance. It would take too much time, but more importantly, they all point to remaining closed, virtual. All of those done correctly, all of those done incorrectly, those with robust data sets and those with scant, all show that West Orange schools should not open. What I decided to focus on instead was yesterday. If yesterday didn't change you, nothing would. Yesterday changed me. Yesterday and today. Yesterday, our president called a broken nation to unify. And today, our president told us that we will no longer be left to figure this out alone. Unity and leadership. Today, our president said that we must open our schools within 100 days if possible. And he laid out how. First, he said we must vaccinate all our teachers and staff. And he said that the full federal authority is going to lean in that direction. Then he said we must have regular testing of all students and staff in our schools. And finally, he said that the feds will fund those safety measures, and that that it all needs to be completed for successful reopening of schools. So I think we need to lean in to successfully reopening schools, but we need to lean into them the way they're defined today by our federal government. Those 3 requirements get our schools open as soon as it's safe. And then what happens is we now have that void of a national plan, national leadership, national guidance, national funding. We now have that void filled. And what we can do is let go of that anger and division and all of that hate that's been going on, because we can all be better than that. We all have the ability now, because of the change in federal leadership and the expectation that we open our schools, to get it done. But we need to get it done in a way that protects and leans towards doing it safely. So I really think you should look at the guidance and the expectation that was set at a federal level, because within a week, I think they said the federal Department of Education, the federal Department of Human Services is supposed to give you direction. Imagine if you've reopened 1 week and you have to switch gears because the feds are requiring you to do some testing, right? So like just in my mind,
Ms. Bennett, just in fairness to everyone else.
yeah, I understand. Like 2 sentences. In my mind, look and see what the federal government is going to guide and direct you to do, because that is likely going to force you to change course. And the last thing you want to do when you go ahead and start your reentry is to have to double back because there's a new expectation that is going to help you do it successfully. Thank you.
Dr. C, do you want to move on or?
Yeah, I'm just, I'm processing.
Okay.
I'm processing. I don't think there were any questions in there, just some impactful points.
Okay. Next speaker is Anna Samanamu.
Yes, it's pronounced correctly. Thank you.
Thanks.
So yes, good evening and thank you for your willingness to like stay over hours to like hear each and every one of us. I do have had the distinct honor in speaking to Dr. Schurz before, and I will only mention comments right now because of the time constraint. And Dr. Cascone, I really do respect you and I do admire you. And I said that from the first time I met you. And I know you probably forgot, but it's something that needs to be said. And President Triggs Scales, I haven't had the honor of meeting you, but I do know that the leadership that the board has now, it's the way it's meant to be. And I did email you, Dr. Cascone, some like a few questions I had, including some of the data that I have come across. And I just want to point out that I have started going to West Orange High School. I'm a paraprofessional, so it's an experience that I never thought I would be a part of, and at the same time, I have I witness how my students are developing each and every day, like mentally, and it's frustrating. It's frustrating to see like how do you think I should feel when I hear my student tell me I want to give up? How should I know that's a minute, but I'm just going to go as quick as possible. How can I respond to another student of mine when he tells my colleague and I that he's depressed? Like, how can I deal with another student crying on screen because of the fact that he misses all of us and that he wants to socialize? And coming from a perspective from somebody that I prefer being transparent about mental health because it's something that needs to be talked about and should not be seen as a taboo topic. But understanding anxiety and depression, I suffer from those two and also PTSD. I know each and every one of us is going through a traumatic experience. And at the same time, I just wish that our voices can be heard even more. Like I don't take this against any parent at all because for one, I'm not a parent. I'm still my parents' like daughter and they're like over age and I have to go out and work and then come back and see how they're doing. Like I'm a young adult telling you that you know, I live a whole different life. I have to often go see my grandmother who's homebound. And, it hurts me that a lot of other people can't do that. And yes, I can consider myself fortunate, but I don't think that way at all because our students should be our number one priority as well as the teacher's priority also. Like, I mean, that's all I feel like I could say right now, and I will say that with like the utmost respect. And I know my tone can be a little off right now, but yeah, that's pretty much what I feel needs to be said. And I just hope that I can hear back from you, Dr. Casco.
Thank you.
Dr. Cascone, I'll just tell you quickly that while teachers on the whole have the highest respect for me because of the nature of the profession, professionals like this, so I know she attends workshops. When we're doing parenting workshops or professional workshops, she's always registering. So people who put in the time and the effort and always want to learn and are self-reflective. She's talking about her tone and recognizing how she's coming across. These are people that I hope stay in the profession and rise into leadership positions, because these are people who just are so special.
Thank you, Dr. Scherz. Appreciate that.
The next speaker is Chris Moses.
Hi. I was wondering if there's been any recent consideration to the concept that the teachers are being asked to simultaneously teach two classes, the one that is live and the one that is online. Are they able to do their jobs well for my student or any other student? Is bringing only the teacher and not the students into the schools give them the opportunity to be better educators for us? I know I'm a better employee and more productive when I'm at the office as opposed to working at home these last 10 months. Is there a value to only having the teachers go to properties and possibly students who are in those highest needs? Does having students on site 4 days a month truly have a positive value on their education or their mental growth? Or does the split focus of the teacher give our students a worse education? And if so, which is the lesser of the two evils? Please recognize this is a long-term decision you're making or have made, which I'm okay with. I'm just trying to throw out some new thoughts. And it looks like it'll take, I think one of the doctors says, upwards of 47 weeks until that 4 million people could get vaccinated in New Jersey. This is a long-term decision that's being made. And in a hybrid model, it will be looking like we'll be in a hybrid model until at least the first of the year, 2022. Is that really the best way for our students to be educated? It's not really about a health question. It's more of an education question, Dr. C.
Yeah, I mean, there's a lot there. I'm gonna start with the last part of it, which is I think as we start to look towards next year and recognize that it's probably not going to be normal next year. And what can we learn from this year with additional long-term planning to say, do we need to move in a direction where, because we might very well have students who are not coming in and want to be given the option to do virtual again. And do we establish cohorts of virtual teachers who are not comfortable or not able to come in that are exclusively teaching virtual students? Now, a small number of districts have been able to pull that off this year, but they've typically been very small districts that have been able to do it because it's just on a much smaller scope. I have not seen a district of our size that's been able to figure that out logistically. And part of it is just the nature in which this timeline and planning is played out. And even just trying to understand and ascertain who would be coming in and who wouldn't. And by the way, it just occurred to me that I never addressed Alex Mizrahi's question about the hybrid. I've messaged out on the hybrid now for a number of weeks, and we have been having people who some people who have been calling in, principals as asked to do so and switching into the virtual. But the cohorts that we have presently and have confirmed are pretty solid. I mean, obviously when we come in, we'll see the extent to which our cohorts are accurately reflected in those that come into school. But we're fairly confident that the students that we have on record as doing hybrid, unless they've called and indicated that they want to go virtual, are in fact cohort. And getting back to your question about, and actually I would pose that question to Dr. Scherz. I know how I feel about it as a non-mental health professional. Just as a layman, I think that we're in a place now where there is a value to simply the normalcy of the behavior, the routine of the behavior, of actually getting out of bed, getting out of the house, getting on a bus, going into school, passing somebody in the hallway, interacting, albeit behind a mask, with a teacher. And I don't know if you can quantify that or qualify that, but to me, we're at a place now with, after 10 months, almost a year of being isolated from one another and not having normalcy, I think there's more value to that than we might think. But I don't know. Maybe I would toss that up to Dr. Scherz and see what he might have to say about that.
I suspect that the majority of us are craving, some kind of normalcy, and educators want to get back. The greatest percentage of them say that teaching to remote students and to students in the classroom is an incredible challenge and stretching them very thin. And it's not done, it's done out of just the necessity because, there aren't enough teachers. It's a terrible situation. So I know that, folks want to get back into the classroom. They want to do it safely. They're worried about their students. So everybody has good intentions. And it's just so frustrating that there aren't clear right or wrongs here. There's good arguments to be made all around. And it makes it an impossible decision because half the people, are going to be concerned about whatever decision is made.
How are we doing? Thank you, Dr. Scherz. Mrs. Tomasi, how are we doing?
We have 5 more hands up.
Okay.
And the next speaker is Lauren Salvatoriello.
Hello?
Yes.
Okay. Hi, thanks everyone for staying on so late. My name is Lauren Salvatoriello and I'm a special education teacher in district, and I was back in person with my students in October and this past week. I'm not sure you've heard from someone in my position yet. Abraham Maslow, who created a theory of psychological health known as Maslow's hierarchy of needs, describes how basic needs must be met before one can climb to reach self-actualization. One of the needs, safety, a basic need for survival, is not being met because we are in a war against an invisible deadly virus. Yet I come into close contact with people who don't wear masks correctly, take their masks off, and I'm physically prompting students with no social distancing. I have come into the building, I have come into contact for a few minutes with a staff member who came into the building who was previously possibly exposed to COVID. This aspect of my job leaves me anxious and stressed. I've been dizzy, sweating, even though my windows are wide open, and sick to my stomach. I have a headache at the end of every day, and my throat is sore because of the volume at which I need to speak, which leaves me anxious about it being a symptom of COVID or just a symptom of talking with 2 masks on. I've cried every single day. I haven't hugged my parents in almost a year because it's not safe. I will continue to try my hardest and do my job, but I ask you this: if my basic needs are not being met as an adult, how can these needs be met for my students? And also, I've heard you talk, Dr. Cascone, about mental health things that are in place for us staff members, and I'd really like to know a little bit more about that. Thank you.
Dr. Scherz, I don't know if you want to talk about the teacher coach platform, that we have, that our teachers have access to, the trainings they have access to, and just Ms. Salvatore, if your building leader, your school principal, or your department supervisor, hasn't oriented or pointed you to those resources. But Dr. Scherz, you want to talk about the teacher coach platform that our teachers have access to?
Sure, and that was so well said. I know you've probably waited hours and it sounded like you wrote that out and you thought through it and you did some research and you put in theory and it was personal. It was just really so well articulated. I know that wasn't easy to do. And the idea of getting needs met is so critical because if we can't get our needs met, it's like a car without an engine or an engine not running right. And the tricky part is that everybody gets their needs met a little bit differently. So how an adult might get their needs met might be different from how a student gets their needs met. A student at home, when the parents might be fighting or there might be tension or they might be alone because their parents have to work, might not be feeling safe and secure. So going to school might help that. Whereas a teacher might feel terribly unsafe physically. So it's nearly impossible with one decision to help everybody. But know, and this might feel inconsequential with what you're experiencing right now, but know that, if you go to your West Orange portal, there's support around stress and anxiety. And again, it may not feel like nearly enough, but there are also workshops regularly and webinars that you can look on the calendar and make suggestions, for more that's needed. And I wish that there could be more to offset, the terrible angst of coming into the classroom. It's really a terrible thing to have to be a teacher who's already sacrificing a tremendous amount, and now to feel like you're having to sacrifice, your health and wellness. It just feels terribly unfair.
Thank you, Dr. Schurz.
Okay, let's see. Oh, I hit the wrong button there. Next up is Shannon, but Shannon, you might have an old version of Zoom, which means that, let me see if I can promote you to panelist. Hold on. Could you make sure that your tile is turned off? Okay. You can go ahead and speak. Shannon, can you hear me?
Sorry, I just unmuted myself. Sorry.
That's okay.
So I have some random questions, I guess. Is there any way that is any professionals, doctors, scientists, whatever, measuring the effects on, the children, from the effect of not being in school for a long time? And also I was wondering why the ventilation wasn't an issue before the pandemic. Also, I had a comment on the issue of public trust. I personally, as a parent of West Orange students, I have traveled out of state to visit family, and teachers may have noticed that during Zoom school or whatever. But like if we were going to school, we wouldn't be going anywhere else. So that was just my comment on that. And then dang it, I can't remember what else I was going to say. Oh, is there like any teachers who are actually willing to teach in person? And is there like a survey throughout the district to like measure like how many teachers are willing to teach in person versus the teachers who don't feel safe, which I totally understand that they don't feel safe. But, is there any way to accommodate the teachers who don't feel safe, or are they the majority within the district of the teachers?
Okay, thank you.
Yeah.
Yeah, I think it's, we haven't approached the process, in that manner up to this point. In terms of, having a cohort of, I don't think it would work from the standpoint of, I only think that model would work if the teachers who were on site were not necessarily providing content area instruction, or really there only for support and things of that nature. Because how do you handle that from an equity standpoint, where one third grade class has a teacher that's in, and another third grade class doesn't have a teacher that's in, and how do we address that equity with students who have different things available to them? I think it's, I also think, and we haven't done a survey, but my sense is that it would be at least a 50-50 split, if not more skewed toward teachers who didn't feel safe. And again, how do we staff those classrooms, for, all those students, to manage those students when we're in the school. It would be very problematic, to be able to do that. But as I said, I do want to take a closer look at maybe if we can be a little bit more accommodating in some ways from an HR standpoint. But I think that would be very, very challenging to try and operate the school district if we were in fact going to have students come in.
And there is research, on the long-term effects of isolation, but they're more recent because that's the kind of research that's very hard to do. And they're looking at things like the myelin, which is the insulation sheath on nerve fibers, and the hippocampus, so how memory is affected, how long-term processing is affected. But right now it's just speculative, but there's concern that this long-term isolation can actually do harm, not just to the psychosocial, emotional learning of students, but also to intellectual and cognitive development.
Thank you.
Okay. The next speaker is Lily Bloss.
Hi, I just wanted to make a overarching comment. I've been kind of spectating on these calls. Haven't really commented much, but Dr. Cascone, I was thinking about actually reaching out to you because the folks on the phone kind of have the easier job of criticizing the decisions that you make and why you make them and peeling everything apart and dissecting it. But no one on the phone would trade, like you said, would walk in your shoes. Just want you to know that there are people in the audience who realize this is not what you signed up for. This is not what anyone signed up for. And I also want to just make public note that it's not your responsibility to guide our kids through this. It's our responsibility to guide our kids through this. And most of that is going to be by example. That's going to be by giving them the truths that they can handle and helping them navigate the ones that they can't and moving them forward without keeping them stuck. That's our job. That's not your job. So I just wanted you to know that all of that pressure shouldn't lie on your shoulders. It's our responsibility as citizens and as our kids' parents to model how we feel is the best way to get them through this and to get ourselves through this. Because if we're focused on getting them, keeping them moving forward, then that should help us move forward with them. So amidst all the criticism, I just didn't want that to kind of get lost. A lot of information was shared today. A lot of information will continue to be shared because none of us have been through this before. I think the issue with COVID in general is that this particular virus is requiring all of us to not only think about ourselves. And that's what the challenge is. This is a challenge that hasn't come with any other pandemic that we've been exposed to. So a lot of responsibility lies on us, and I don't feel like it's fair for everyone to expect for all of that responsibility to fall on you. So just wanted to kind of make note of it because it seems a little unfair, the kind of arrows that come your way sometimes. That's all.
Okay. Well, thank you, Lily. That might have been the nicest thing anybody said to me in a long time. So I appreciate it. Thanks so much.
The next speaker is identified as concerned teacher.
And I am. It's Mark Maniscalco. And first, I want to say it's an honor to come after the woman who just spoke. She was eloquent, and I appreciated her words. And thank you for this another long evening. President Biden says that the next few weeks are likely to be the worst we've seen, with perhaps another 100,000 deaths in short order. He signed orders to make vaccines more available for teachers because he knows that a return to school without them is too dangerous. He hopes to see most schools open within 100 days. Not today, not tomorrow. He knows that's too unsafe. His goal is 100 days. And in that time, he fully expects 100 million vaccine doses to be administered. That's not 47 weeks. That's 100 days and 100 million vaccine doses. And of course, vaccines will not be a perfect protection, but they will offer a level of physical protection and mental solace that we do not have now. Death is knocking at the door, and when that happens, rational people put up barricades. Instead, we seem to be opening the door and inviting him in for tea and a game of chess, hoping we can outwit him. It doesn't work that way. Yesterday, Cedar Grove High School opened for just 7 days with students in for 3 or 4 days at most, saw a viral spike that caused it to close. We will be much the same. People will get sick and some may very well die because of it. My question for you is this, and it is an impossible one for you to answer. If even one student, one parent, or one teacher dies as a result of opening, will it have been worth it? Thank you for this evening. Thank you for all you're doing. We know you're doing your best to guide us, and we appreciate your work.
Okay, and let's 2 more hands went up. Oceana,
We have how many up, Ms. Tomasi?
we have 3 hands.
Okay, that'll be our last 3 for the night.
Okay.
I want to say thank you to Dr. Cascone for the time and effort. I'm sure it was my kid that you saw at Roosevelt today, and I'm so happy that the kids with special needs were able to go to school. But like I was able to hear the reports from some of the paraprofessionals, and what comes to mind is what are the trainings and what avenues do you have to help them, especially with dealing with this issue? Because this whole thing has a traumatic effect on all of us as parents and as on these paraprofessionals as well. And also with regards going to school, I have other kids who are not in the special needs class, but the fear is what will happen when they go back to school. But I see them every day and I see the effect of them sitting home and the isolation and everything. And it's a difficult situation as well, as somebody said, for you to take whether or not the whole district goes back to school. I just hope that the decision will be taken, but I just want to encourage all of us that we should just be hopeful, and each day we see the sun, each day we see the new day, we have to be grateful and move on. It's difficult, but there is hope for tomorrow. Thank you.
Thank you. The next speaker is Dee Sinisi. Did I say your name right? Dee Sinisi? You are muted. Okay, I'm going to move on to the next person. And that is Jessica Lee.
Hi, good evening, almost good morning. Thank you so much. Thank you so much, Dr. Cascone and Ms. Scales and I forgot your name. I can't even, Dr. Shorts, I believe. I am a teacher in district, and I just wanted to say I am thankful for the administration of West Orange and for you, Dr. Cascone, for all you've done for us as teachers and to protect the students as well. And I just want to reiterate what Deb Reese said about the capacity issue with rooms. It's not just the special ed rooms, but the general education rooms, that some are at a capacity of 8, but yet we have more than 8 students plus faculty in the room. And so there've been accommodations like, okay, I'll make the desks 6 feet apart or put more in, or I'm just a little concerned about what happens because some cohorts are larger than others and some students are opting in more to come in person. So if the administration can have something in place to make sure that, you know, everyone stays safe, but we're within capacity or within, you know, the 6 feet, whatever it is, I think that would make things a little bit easier going back, not having to think about logistics like that, but just having to focus on the kids and of course helping them to stay safe. But I think that's an issue that really needs to be looked at, the capacity of rooms and the readiness of rooms. And, you know, I know that there's some rooms that are not ready, or they said it's not, it said it was 5 points, but now it's not, whatever the logistical issue is, I don't think the teacher should have to be dealing with that at this point. knowing that we have to come back and other teachers are already there. So I just really want you all to take a look at that. That would be greatly appreciated, the capacity issue of rooms. Thank you.
Okay, and the final speaker is Keisha Urella. Keisha?
Hi. I'm not going to drag it out and speak pertaining to going back into the buildings because I've already mentally prepared myself to go back. The only thing I did want to bring up was one concern that I did have. When I went into the building, I do work for the district. I'm sorry I didn't start off that way. My name is Keisha Urell. When I went into the district, the building, I'm sorry, last week, the temperature monitors weren't working. So I wanted to just bring that to your attention because what I was told was because it just kept reading low. So all of us just walked in because the person told us, you know, if it's just reading low, go ahead. That means you don't have a temperature. That kind of concerned me. So I just want to make sure that I brought that up to your attention. So that way we can take the proper protocols, know exactly what to do when things like that occur, maybe having an extra temperature monitor to make sure that if there is an issue with the monitors that are set in place, to have a backup plan. I just want to make sure that moving forward that we're safe and we take the proper measures because that's basically everyone's concern at this point. So we just have to mentally prepare ourselves and get it together and just make sure that the facilities are ready for us to come in. And that's all.
Thank you.
Thank you. I do believe, Dr. Cascone, that that is it.
All right. Well, Mrs. Tomasi, can't thank you enough for hanging in there with us. And, you know, to the 100 some odd folks who are still on, thank you for sticking with us all this time. And we appreciate it, all the comments and the feedback. And Dr. Schurz, you know, if I liked you before, I love you now, buddy. So appreciate it. You're a great professional and a good friend. So thank you for taking your time to be with us tonight. Your words were wise and healing as they always are. So it's appreciated, sir. And have a good night. Stay well. And you too, Ms. Streak Scales. Good night, everyone.